It's all right, I'll start when she gets on. So these pictures just show nice normal arterial wall segments. So the goal for us with our carotid scans is to make sure that we're perpendicular to those vessels. So a nice 90-degree angle to our vessels will give us a nice image where we could see those intimal walls and the intimal layer of our vessels. So this is important for us when we want to determine plaque formation and look for potential for intimal thickening. Because being off axis a little bit, we start losing some of that intimal layer, and we can create also the sense of false thickness also if we're a little bit off axis as well. So this lecture is going to go into assessment of plaque, how we survey for plaque, a couple of the techniques and methods that we use, a couple of terms that we use to describe the plaque. So we want to understand the severity of that plaque. So how narrow is that vessel lumen, and then the extent of that plaque? How long of a segment of vessel is affected? And then we're also going to discuss how do we characterize different plaques that we're going to encounter. The surface features of some of these different plaques, what they look like sonographically, and then get into a little the pathogenesis of plaque formation, like why do they form, how do they form. So for us, for carotid Dopplers, or whenever we're assessing for plaque, we're going to utilize our B mode, so our 2D imaging, have nice grayscale images. So this 2D will allow us to determine some of the surface features and the texture of the plaque. So when we start getting to different types of plaques, we wanted to decide if that plaque looks homogeneous versus heterogeneous. Is it complex? Are there areas that appear more anechoic? Maybe this is a hemorrhagic plaque that's bleeding. Because this 2D presentation of our plaque helps us to get a good idea of what that plaque is comprised of and the potential risk that's involved of that plaque potentially starting to break down and cause emboli or microemboli. So we'll learn that homogeneous smooth plaques are a lot more stable than plaques that appear heterogeneous. So early plaque, so we want to detect plaque early.
Can you say that again, Dad? I'm sorry.
We're going to see in a moment when we start getting into the different types of plaques that are homogeneous and smooth in extrotexture, and they have smooth contours, are much more stable. So they're less likely to embolize, break apart, and start embolizing than a plaque that looks heterogeneous, that's complex, and has irregular borders, that's ulcerated, has ulcerations to it. So if it's smooth and homogeneous, that's considered a more stable plaque versus something that appears heterogeneous and ulcerated or undulated. It's got, the walls of that plaque are not nice and smooth. So those have a higher propensity for potentially breaking apart, embolizing, and creating stroke, causing stroke.
Okay.
So with our plaque surveillance, again, we want to characterize the extent of that plaque and the severity of the plaque. And we're going to describe that plaque sonographically. So that's why our grayscale imaging is very important. We also utilize our color flow as well, because sometimes we might have some plaques that are very, very hypoechoic, very dark in nature. So we may not look at like a severe plaque. When we put our color on, like, wow, that's a lot more significant than I thought it would be. So we'll see that color also goes into it as well. When we're doing our plaque assessment, we want precise measurements of the plaque at locations that are easily visualized. And we want to use an imaging plane that can be reproduced. So with detection, so atherosclerotic plaque. Yeah.
Sorry. When you say you put the color on it, what do we see when we put the color on it? Like how?
So if I had a vessel that had maybe like I could see the plaque here,
Yeah.
there's some hypocode plaque, like just above it, so I could see this plaque here. But there was a layer of like hypocode plaque, maybe that I couldn't visualize very well.
Ah,
So I might think that the plaque is maybe only like this area here.
got
I've
it.
got a layer of soft plaque that's over it, so when I put my color flow on it, the color flow would go around that plaque, so like, this part will fill with color.
Oh, sure. Okay.
And it would unmask maybe a more severe stenotic lesion or more severe plaque that just seemed more hypoechoic or even anechoic.
Yeah. Okay.
That's why we also use our color as well. So we always do grayscale, we always do color for all the segments that we're imaging for carotid.
Makes sense. Thanks.
We'll learn how to do an intimal medial thickness as well. So we're going to take measurements of the intimal thickening. Just remember normal intimal medial thickness in the CCA is greater linearly with age and in response to early plaque formation. So the older you are, typically the thicker your intimal layer is going to be. When we have an intimal thickness that's greater than 0.9 millimeters, this is considered abnormal and is likely associated with sonographically visible plaques. So when we start getting into, when we discuss the pathogenesis, we'll see that basically what's going on is cells, white blood cells are entering into this, through into the intimal layer, crossing through the intimal layer, that thin endothelial layer into that medial layer, or in between those two layers and depositing those fatty deposits in there. And that's what's leading to the formation of this plaque. So as that intimal layer starts to thicken, can be used kind of like as a precursor to the potential for plaque developing in that particular site or that area. But when we see intimal thicknesses basically over 1 centimeter, I'm sorry, over 1 millimeter, this is usually going to be a site where we could see some visible plaque associated with it. So with detection, reproducibility is very key. So with our detection, right, we want to be able to determine the presence of plaque. Is there plaque? Yes or no? We want to be very specific with the location of that plaque, because once we start, documenting that this patient does have plaque formation in their carotids, they're going to probably be coming back for follow-up ultrasounds. So we want to make sure that, we're imaging in the same locations, we're measuring in the same locations. We want to determine the extent, the thickness or severity. We're going to be assessing the texture of that plaque. So we want to determine, again, is it homogeneous or is it heterogeneous? Does this plaque look smooth in nature, or do the walls of that plaque look more undulated or ulcerated? Are there any areas within that plaque that could potentially be hemorrhaging or bleeding? Are there areas that look anechoic within that plaque? So all this information, needs to be included in your report. And when we're assessing plaque, we're always going to assess plaque in 2 planes. So we're going to scan in sagittal, and we're always going to scan that plaque in transverse. The reason we do this is because we need those 2 imaging planes in order for us to determine extent and severity of the plaque. So this is just showing normal intimal medial complex. So this is a normal vessel showing that intimal and medial layers. So if your lab does measure intimal medial thickness, There is a protocol that we use. So we're gonna measure that intimal medial thickness. Starting at that just prior to the bulb in our distal CCA. So typically we measure the distal CCA 1 centimeter before that carotid bulb. And we also measure the proximal ICA 1 centimeter from that flow, from that bifurcation. So we go from that bulb 1 centimeter proximal to that bulb. And then we're going to measure the intimal medial thickness of the ICA about 1 centimeter from our bifurcation.
So you're sorry, you're measuring from the bottom line to the dotted line, that very small measurement.
Yeah, so you would measure intimal medial thickness, just that the layer of that.
Yeah.
I go back to this, we're measuring. Oh, come on. Stay. It's going crazy.
So that's sort of anechoic
so
area in the middle.
Yeah, yeah, the anechoic area. So we go right up to the echogenic line and measure to the inner wall of that vessel. So it's the intimal and medial thickness. You're measuring both layers.
Because it's saying that the intimal layer represented is just a reflection on the previous screen. So
it is. So we don't actually really see that intimal layer because it's so thin. This is that echogenic line is just a reflection of the actual intimal layer.
Okay, so it's literally so you have the really hyperechoic area there, and then right above that there's this small dark space.
That dark space is the medial layer. Yep.
Medial layer. Okay.
And then the bright outside is the adventitia or outer layer.
And seeing that that reflection is going to be common when we're scanning.
Yeah, so that intimal layer, we see it. We our goal is to try and see that intimal layer. So you could kind of see the intimal layer here, see the intimal layer here.
Okay, got it. Okay. Okay.
Wait, if I'm correct, you said that the intimal layer, the intimal layer is a reflection of it, but it doesn't depict whether or not it's a true size, right? No? Hello?
Does it depict if it's the true size?
Yeah, like if it's actually a real, like actual reflection of the intimal layer, or is it just part of it? Because I think I've like vaguely remember you saying that like, and maybe it's a reflection, but it doesn't show all of it, question mark?
I'm not sure. I'd have to find out.
Okay. I wasn't sure.
Yeah, I'd have to like if you're seeing like the entire the intimal layer is just it's very thin. It's just comprised of a thin layer of smooth like epithelial cells.
Yeah.
So I think it's just it's so like reflective and thin that like the ultrasound beams kind of maybe just reverberate and we get just a reflection, kind of like almost like a mirror image artifact of the actual intimal layer. So this is just showing how to measure points for intimal medial thickness. So you're measuring, you know, from that intimal layer, including that medial layer up to that border of that adventitial layer. So this one looks a little off, but this one's, you know, accurate here where you have the medial layer and then the hypoechoic, I'm sorry, an intimal layer and the hypoechoic medial layer. And you include both in your measurement. This caliper, I would have dropped down a little more here. Gone right to the border.
Okay, so you do include the.
Yeah, so this one over here is
Yeah.
correct. Yeah, so you're including that hypoechoic medial layer and you're including the echogenic intimal layer in your measurement. So like they did it right over here. So they went right to the outer edge and then right to the inner edge of that adventitial layer or the outer layer. So same thing here, right up to that echogenic now outer layer. Showing some more normal intimal thickness versus development of what's called a fatty streak within the intimal layer. And this is more homogeneous hyperechoic plaques.
Wait a minute, Dan. I'm sorry. The previous slide, you said the fatty streak. Where is that pointing to? What is it?
So when we get into actual plaque formation, forward. So we start getting fat deposits like within the plaque itself. So before this plaque is going to potentially progress, it'll sometimes transition from some of these smooth plaques that are like this, where in between the layers, we just have like what's called a fatty streak or a fatty deposit. So this kind of homogeneous area that's within the medial layers, what's called a fatty streak. As that plaque starts to age and progress, it can start to bleed and then become more ulcerated and heterogeneous. So early in this stages of plaque formation, when the plaque is first starting to form, we call it a fatty streak. So that's more plaques that are homogeneous and smooth like this.
Okay. So if we go back to that slide we were on, is it actually pointing to the
So yeah,
the
so in
top?
here, yeah, like
So it's saying the fatty streak is on the left slide, not on the top of
Yeah.
the slide.
yeah, no.
Right.
Yeah.
Okay.
Yeah, it's just as referring to this slide.
Gotcha. Sorry.
So a couple of important terms when we're doing plaque assessment for carotids is determining the extent of the plaque. So extent refers to the length of the vessel affected by the plaque. So how long of a segment is this plaque? How long of a segment of the vessel does it affect? In order for us to determine extent, we need to be in a sagittal or longitudinal plane to that vessel. So that's why we always image these plaques in two planes. So in order to determine extent, we need to be in sagittal or longitudinal to that vessel. So this will help us to determine exactly what location that plaque is in. Does it extend to other vessels? If it's in the bifurcation, does it go from, our bulb into the CCA or into the ECA? I'm sorry, into the ICA or ECA? Also helps to get good characteristics, is it smooth or does it look more ulcerated? Also helps us to get a good idea, if it's heterogeneity. Is it homogeneous, heterogeneous? So this is another transverse view showing intimal medial thickness. Transverse view. So in addition to extent, we also want to determine the severity of the plaque. So severity can also be referred to maybe as the thickness of that plaque. How thick of it is that plaque? So when we think severity, we want to know what is the degree of luminal narrowing? So how much of that vessel is still patent versus how much of that vessel now is, filled up by plaque. And in order for us to determine the severity of that plaque, this has to be done in our transverse view. The reason we do it in transverse view is if we're in sagittal, trying to determine the thickness or severity of this plaque, we might be clipping it at an improper angle, and we might overestimate or underestimate the severity of that plaque. But in transverse, we can see all walls of that vessel, and we can get a very good idea as to the degree of luminal narrowing. So with this, we can use terms like minimal, moderate, severe. A lot of labs will use just greater than 50%, less than 50%. This is just showing how in transverse
Sorry.
view, like if
Sorry.
we were,
What does FU mean?
what does that for you mean?
Yeah,
Well-
generally, like, is that? What
Do
what
you
is that?
do you like jazz, Rochelle?
I think it means follow up, but I don't know.
Oh, follow up?
Follow up.
Yeah.
follow.
Okay. Okay, thank you.
Generally do a follow up on the basis of plaque measurement.
I peep what you were trying to.
No,
was the same thing.
I didn't.
But I was like,
actually-
nah.
I didn't see the follow-up ahead of it. I just read generally do not FU on the basis. So couldn't think of it. Okay,
We're
thanks.
keeping it
Sorry.
clean here.
I'm sorry.
Rochelle, I'm writing all this down for Friendsgiving, just so you know. So.
What does that for you mean?
Sorry.
What does? No, I'm just messing with you. All right. Okay. I did write it down though. Okay.
Hope you're feeling okay, Ryan.
Oh, I'm not. But thank you.
Sorry.
Okay.
So this is just showing that if we were in a longitudinal plane and we were scanning through the vessel, maybe in like this plane, what that plaque could potentially look like if we scanned along in the scan plane in sagittal. We would get a view like that. And if we were, in this scan plane, scanning across that vessel with D, the plaque might look something like that. Whereas this would appear, very ulcerated or irregular. Whereas this looks, homogeneous, a little more smooth. So we can make the plaque look very different depending on, what scan plane we're going through. So that's why transverse, is very important, as well as our longitudinal image. So this was the same vessel that they imaged in sagittal. So slicing the vessel one way made it look very, severe. But like maybe only this little area is patent and all this is plaque now. There's a little more coming on that posterior wall. So maybe there's only a thin, small lumen that's open. And then if you clip it a certain way, you can almost make it look like there's nothing at all. But in transverse, you get a good idea. You see some plaque along that anterior wall, some plaque along that posterior wall, and a fairly decent size, not fairly decent size, but at least probably at least 50%, if not more, is still patent for that vessel lumen.
So like when Kirsten did the area measurement, like that story I was telling where she wanted to compare the area of patency to the area of the vessel that was, had the stenosis, then obviously you need to get that in transverse. And sometimes it really doesn't matter if it's, you know, heterogeneous or homogeneous. You could still use sort of that area measurement to you
Yeah,
know.
you can still use those area measurements. I'm surprised you didn't went that far. I mean, sometimes they'll allow you to just kind of eyeball it. You know, you can look
Yeah.
at it like, yeah, all right, that's greater than 50, or that's probably greater than 75. And
Yeah, it's because the velocities didn't indicate more than the 70% stenosis, but
Yeah.
the area did, so she wanted to be precise.
yeah.
I think. Okay.
So we might have, you know, incorrect plaque assessments due to acoustic shadowing. So oftentimes you're going to come across patients that have these calcified plaques that create this acoustic shadowing. And we have no idea what's going on, you know, on the other side of this acoustic shadowing. It's very hard for us to determine, you know, the extent and, well, not extent, but the severity of that plaque due to this acoustic shadowing. So we know that the plaque goes, you know, from here to here. We know the extent of it. But in determining severity, you know, that's basically becomes almost impossible for us. And then we have to rely a lot on our velocity measurements, you know, before and after this area's. So it's rare to have a plaque like this. Where 50% diameter reduction equals a 75% area reduction, but that's what we use as our, you know, as our golden rule when we're talking about our measurements. Fortunately, a lot of the plaques look more like this. When we compare diameter to area. So this is what your sonographer did in the lab right there, right? That you measured the area of the vessel and then
Yeah.
the area that was open like that.
Yeah.
That's why multiple view evaluation is important when we're looking at these plaques and these stenoses. So, right, particularly if you have any areas of high grade stenosis, you know, particularly if your Doppler measurements are kind of borderline or on the cusp, it's always good to try and image these things in multiple planes. And that's part of the reason why we always do, you know, a transverse assessment first. The transverse assessment gives us a good view of our carotid arteries, you know, in terms of plaque. So we kind of know what we're up against before we start doing our sagittal assessment and, you know, our Doppler measurements. Some more images for carotid plaque. Be a nice smooth homogeneous plaque, so we have nice even echo textures throughout the plaque, but it's a fairly long segment of plaque, so the extent of that plaque is pretty long. This looks like the patient's CCA, or it is the patient's CCA. So now this is getting into the carotid bulb. So this looks a little more heterogeneous. We've got some areas that appear more echogenic, areas that are more hypoechoic, or and then some areas maybe that might be a little more anechoic. Some plaques again could be calcified. So in this one, there's a posterior plaque that's calcified. You can see the posterior shadowing. These little areas here, this might be some twinkle artifact. So this might be a little area of calcified plaque that's twinkling. So our characterization of plaque is important because it helps to determine how vulnerable that plaque is, or how unstable that plaque is And if it has a high propensity, or if that patient is high risk for that plaque potentially breaking apart and embolizing. So we can use, our plaque characterization to determine a patient's potential stroke risk. Plaques that are considered vulnerable or at a high risk for potentially breaking apart and embolizing, those are characterized by having a large lipid-rich core that appears necrotic. So when we see these plaques, they might look like there's areas that in it that appear anechoic or almost liquid, because those plaques are probably are undergoing a process called intraplaque hemorrhage. So it's actually blood or bleeding inside that actual plaque. Some of those plaques might actually have some vascularity to it as well. So this process of plaque formation is an inflammatory process. It's a process of damage, repair, damage, repair, damage, repair that's going on repeatedly and over that leads to the buildup of these plaques. Some plaques may appear very hypoechoic. So this is a nice example of some of those hypoechoic plaques. So with 2D, you may not appreciate that plaque as being that significant because it's very hypoechoic, very dark. But when you put that color on, you all of a sudden realize that vessel is severely narrowed. A lot of vulnerable plaques that are unstable also appear predominantly hypoechoic or sonolucent. They'll have irregular surfaces. So plaques that appear very kind of undulated or don't have nice smooth walls to them are considered vulnerable. Some of those plaques can create nice surfaces for thrombus formation. So with plaque characterization, we can talk about that plaque's echogenicity. So if it has a low echogenicity, it's very hypoechoic, dark. These contain a large amount of lipid material, and they can be hard to visualize sometimes, and our color Doppler can help. Plaques that have moderate echogenicity, these are considered fibrous plaques. They're much easier to visualize. So these would be more hyperechoic. These contain collagen, it's more cellular content. And then we have echogenic plaques. So some of these would be considered more the calcified plaques that create that posterior shadowing. Calcified plaques can either be focal, say maybe concentrated, just a single plaque in the bulb or the bifurcation, or they can be spread out diffusely through the entire carotid system. So you might see them in the CCA, bulb, ICA, ECA. They can grow quite large with large calcifications that can actually obscure the lumen, like we saw in some of those previous slides. When we have these large calcified plaques and we can't see posterior to them due to that shadowing. So this one's a little lower echogenicity. This is kind of bordering between low and moderate. But again, it's starting to develop that fatty streak within it. So we're getting the deposits of that fatty material, those fatty plaques into that medial layer. These are moderately echogenic now. So we get some increased collagen now within this plaque, and it's becoming more fibrous. This is a nice smooth bordered plaque. This would be more moderate. maybe a little, some starting to get some calcifications within it. Looks like there might be a little shadowing actually. So here we could see some diffuse echogenicities within this plaque starting to develop. So some of these arrows are pointing to some areas that are starting to become calcified. These are plaques that have now become highly calcified. You can see a lot of shadowing involved, and the shadowing extending all the way down, posterior to that vessel as a result of that anterior plaque.
So when we say diffuse echogenicity, that literally means like there's echogenic pieces of plaque diffused throughout the plaque.
That's spread out through. So yeah, diffuse means like, spread out throughout.
Because I know that word is used a lot in the sort of the findings from the vascular lab was, a moderate amount of diffuse plaque. And
Yep.
so, okay.
Wait.
Yeah,
Right,
so
I
if
have
you
a
see
question.
plaque in your CCA, like, there's plaque in proximal mid, CCA, there's plaque in the bulb, there's plaque in the ECA, ICA, that would be diffuse. It's throughout the entire carotid system, if they got multiple areas of plaque rather than a single focal stenotic lesion.
For low echogenicity, when it says large amount of lipid material, do you mean like the lipid material as in the fatty streak or the fatty deposit?
To me, this is more like
Very
that low
vague.
echogenicity when it looks very almost sonalucent like anechoic plaque. That other one that said low echogenicity. This is kind of borderline for me. I don't know if I would necessarily call that low echogenicity. Yeah, cross off this fatty streak. So it's more fibrofatty plaque. So it's a more fatty plaque, more fat deposits or lipid deposits. So this is basically lipid deposit right now. That's fresh lipid deposit along that vessel.
Okay, so to clarify, when they mean lipid material, you mean fresh lipid deposits,
Yeah,
not a fatty streak.
yeah, that fatty streak for me is getting more into this moderately echogenic plaque. So this is that fatty streak when it starts to become a little more echogenic like that. Or a little more hyperechoic.
Okay, the fatty streak is moderate.
Yeah.
Okay.
Homogeneous versus heterogeneous. So this is another important criteria when we're looking at the plaque, because it also determines the vulnerability of that plaque as well. So homogeneous plaques are most likely cellular in nature and commonly associated with intimal hyperplasia or thickening of that intimal layer. Heterogeneous plaques indicate fibrofatty lesions where the presence of calcifications usually leads to shadowing or focal or scattered areas of low echogenicity. The reason this is important is because those heterogeneous plaques increase the potential for embolization. So these could be, a precursor to a patient who could potentially have a hemorrhagic stroke. I'm sorry, hemispheric neurologic stroke. So homogeneous plaques are more stable. Heterogeneous plaques tend to have a higher propensity for embolization. So they're considered more vulnerable. So when you start seeing plaques that have areas that are echogenic, hyperechoic, that don't look nice, smooth, and even, those are more of a concern than homogeneous plaques. So this is a nice homogeneous plaque. Everything looks pretty similar in echo texture. Whereas this one, we got some areas that are bright, more echogenic, a little echogenic here, and then we got some areas in here that look anechoic, very dark. So this might be some intraplaque hemorrhage that's going on, or just areas that are fatty, maybe fatty deposits, we don't know. You can put color on this. You might even see some vascularity within it, but this is an example of something that is heterogeneous. And also, if you look really closely, the borders to this are really irregular. Whereas this tends to have a nice smoother border. It might just be clipping a little bit, but this looks like a much smoother border, than something like this. I'm gonna skip over some of this because this Bluth classification they don't use. They didn't use it in my hospital. They don't use it at Christiana in terms of these types of plaques, type 1, 2, 3, 4, 5. The boards doesn't test on this as well. So these are some nice pictures showing some heterogeneous plaques as well. So this one up here is C. You can see an area in it that looks like very anechoic within that plaque. So that's a good indication that there's probably some intraplaque hemorrhage. So there's probably some bleeding going on within this plaque. So this would be a very unstable or very vulnerable plaque. Potentially, this could rupture and send some of these pieces out and create embolic stroke. The border of it looks pretty irregular as well, especially this portion of it kind of goes up and down. In here in transverse, we can also see areas, that look anechoic. Got some brighter areas, little echogenic spot. And some more heterogeneous plaque. Got some areas that are echogenic, more areas that are hypoechoic, even a little anechoic. Whereas some of these, these are more homogeneous. But this doesn't look good because it's kind of irregular.
But is anything going to be done if it's not greater than what, 75%?
In terms of cleaning them out, no, they wouldn't necessarily do anything. They would just, they'd realize that this patient, is a higher risk candidate for having a stroke. So maybe they would put them on some sort of anticoagulation therapy, potentially. They would monitor that patient.
Come back
But yeah,
for a follow-up sooner.
absolutely, yeah, no, they would have follow-up exams. And they would ask them to monitor their symptoms, for stroke and be cognizant that they're at high risk for stroke. It'd be nice if they can put some sort of filter in there, right? This was a plaque that was a little heterogeneous. It had a large component that was very sonolucent or anechoic or hyperechoic. So with 2D, you really didn't appreciate it very well. And then when you put color on, you saw a high degree of luminal narrowing. So that area that's anechoic might indicate, acute hemorrhage within that plaque or acute bleed. So these are homogeneous and with nice smooth borders. So nice smooth border, nice even echo texture. So these would be much considered stable plaques or non-vulnerable. And some of these high risk. So you see that area that potentially looks like intraplaque hemorrhage. So when you see again these areas that look anechoic or hypoechoic within the plaque, that could potentially indicate hemorrhage, intraplaque hemorrhage. And these are at very high risk for potential rupture and embolization. Some more heterogeneous plaques, got some areas that are brighter, some areas that are darker in it. And some more heterogeneous plaques.
Is that greater than 75%?
This guy over here, yeah, probably would be. Yeah, I mean, you're going from that, down to that. Yeah, just eyeballing it, yeah, sure, it's definitely greater than 75%. But again, you also have to be careful, you could be clipping it a certain way. Where you're making it look a lot worse than it is. So even though this may look like greater than 75% and you're Doppler-ing it and your Doppler measurements don't say that, maybe you're just catching it at a bad angle. So you just kind of have to be careful to fan through that vessel to make sure that what you're showing them is true. And that's why we also do that transverse assessment. So it looks like we're getting, when we're in transverse, this kind of looks like we're getting right into that bulb. So this looks like distal CCA and then bulb and then maybe ICA here. This is probably right at that bulb. So when we're in transverse and coming up, we'd get a good idea doing our transverse sweep first. You can see some very complex heterogeneous plaques now. This is just doing a transverse sweep and the corresponding images in transverse to where they are in the vessel. I'm gonna skip over some of these other slides. So basically for us, when you guys are in Christiana, they're gonna want you to describe, extent and severity, what segments of that vessel are involved, how severe is it? So usually they say greater than 50%, less than 50% for severity. Maybe if you want, you can ask them if you want to describe it as greater than 75%. Or I'm sorry, greater than 70%. You're going to describe its heterogeneity. Does it look heterogeneous versus homogeneous? And does the plaque look smooth versus ulcerated? So does the plaque look smooth or does it look irregular or ulcerated? So those are the two terms you could use, ulcerated or irregular. And then does it look heterogeneous versus homogeneous? So it's really not that difficult. You might also use calcified. So that's another term that they like to use at Christiana describing the plaque. Is the plaque calcified? So is it homogeneous, heterogeneous? Is it calcified? In terms of echogenicity, you can say, it's a hypoechoic, hyperechoic, echogenic. So use your descriptive terms. So just be careful when we're talking about plaque that is ulcerated. So in this case, it looked like there were some ulcerations to this plaque where it kind of looked, irregular. I'm kind of like tracing the borders of it here, So it looked like there are areas where it was a little more ulcerated. And then they got another view on it and it looked a little smoother now when you changed your angle a little bit.
So the smooth view always overrides the irregular view,
Irregular.
surface view.
Yeah, so you can make something look ulcerated, but you can't really make something look, it's harder to make something look smooth. But again, transverse is a good way to assess that better. So with these plaques, you're always doing two views. You're doing that plaque in sagittal and you're doing it in transverse as well. So these are again some sources of error, you know. So there could be an ulcer crater, you know, adjacent plaques. So in sagittal, we just see what looks like, you know, fairly smooth, whereas in actuality, this plaque has a large ulcer crater in it. Or adjacent plaques can potentially look like ulcerated plaques, but it's not. It's irregular. Uh, so this was actually a plaque where blood flow was seen entering into an area that was ulcerated. So this arrow is pointing to that ulcer within that plaque. So this is irregular. We got this crater here where blood flow is entering in. It's very irregular now. And plaque with a large ulcer here. Here's another plaque. So again, anytime we see these plaques that have these dark central areas that look like intraplaque hemorrhage, these are, you know, have a very high risk for rupture, potential rupture and distal embolization. So these patients, you know, are much higher risk for potential stroke. Here with power Doppler, we could see this crater formation now of this ulceration in this plaque. So this was a carotid duplex when they used some ultrasound contrast on board. So here we could see this plaque now. The outline's nice and clear with the plaque. And we could see a concave border. So plaque pathogenesis. So just that term again, atherosclerosis, refers to that deposit of it refers to that lipid deposits being deposited in the intima. Atherosclerosis is associated with fibrosis and calcification. And it's a response to injury of that endothelial lining or that vessel. And that response is mediated by those endothelial cells that line the arteries. So I actually have a nice video that I found that this guy kind of explains the whole process of or pathogenesis of plaque formation that I just wanted to play for you guys.
Risk factors. Now we're going to move into the pathogenesis. So the pathogenesis for today, what this basically means is the genesis, the creation of the disease. For this, I'm going to put 5 steps. So I'm going to come up with 5 steps on how this atherosclerosis process occurs. The first thing I want you to know is atherosclerosis is a chronic disease, a chronic manifestation. So it happens chronically over time. What essentially happens is we have this ongoing injury and repair, injury, repair, injury, repair. And in this process, this chronic inflamed repair process, this is where atherosclerosis manifests.
So that injury happens as a result of things like hypertension. So having high blood pressure causes damage to that endothelial layers. So that's why it's important for us to control a patient's hypertension. Diabetes, like I said before, that sugar molecule is very sharp, very jagged. Actually cuts and slices the inner lining, the endothelial layer of the vessels, creates damage to the inside of that vessel. Smoking, that's why smoking is so bad. The chemicals within that cause damage to that endothelial layer of the tissue. So it causes inflammation and damage to the inner lining of our vessels. So all those things, those three major risk factors that we have, damage our vessels. Having high cholesterol, you're putting basically what it needs for, this process to happen in our bloodstream. So having high levels of cholesterol is the kind of like the building blocks that we need for developing these plaques. So most people that have high cholesterol also have high blood pressure. They also have diabetes. So, when all those factors are working together and then you throw smoking on top of it, you have all those risk factors working together. You're just creating a recipe for developing these plaques.
So the first step I want you to list and write down is the normal vessel. So we have a normal vessel operating before the atherosclerotic pathway begins. So when we look at a blood vessel, let's say we pull it from the coronary vessel. This is the coronary vessel in cross section. What we're going to look for is three. So for a normal vessel, three main layers. We have the intima, which consists of a nice layer of endothelial cells with a basement membrane, a little bit of smooth muscle. Then we go into the thicker layer, which is the tunica media. That's filled with smooth muscle. And then outside that, we have a kind of connective tissue layer we call the adventitia. So we're going to have a normal vessel with those three layers operating nicely. The endothelial layer does its job. Its job is to contain the blood here, stop things sticking to it, and not allow a nice laminar flow, a non-turbulent flow down the blood vessel. So that's step one. Step two, we're now going to move into the endothelial injury. Endothelial injury. So this is the first step, or the first disease step in the pathogenesis pathway. So what happens with endothelial injury? Well, basically it's these risk factors. So for instance, smoking causes toxic agents to irritate the blood vessel, or hypertension, too much shear force and injures the endothelial cells. Lipids such as LDLs causes oxidative stress. In any case, we get this injury starting to manifest. Now, what happens when we get the injury? We start to have things stick to it. So platelets will start to stick to the endothelial cells. Bigger cells like white blood cells will start sticking to the endothelial cells. And what they might start to do is release growth factors. They release growth factors into the wall or the intima of the blood vessel, and that's going to lead us to step three. Step three is basically making the endothelium permeable. Endothelium becomes permeable. And what this basically means is things start to go through it. What we see most notably is LDLs. So the LDLs start to accumulate in the intima. These LDLs, these low density lipoproteins, start to accumulate in the intima, and they go through a biochemical modification. They start to oxidize. And what this does is it further encourages things to go through the wall. Most notably, we start to see monocytes going through. So monocytes, because we did see the leukocytes starting to attach, but the monocytes start to squeeze through into this kind of developing fatty core. And what these monocytes will begin to do is they will change from a monocyte into a macrophage, and they will start eating up these LDLs. And this is going to essentially move us to step 4, which we call the fatty streak stage. And in this stage, we start to see an accumulation of these macrophages filled with these fatty molecules, and we're going to call these foam cells. So histologically, if you were to look at the blood vessel at this stage, this fatty streak stage, we would see these foam-like accumulations that will start to build up in the intima. Now, this is going to manifest over many years, decades. So what we're going to start to see here is the accumulation of this core becoming bigger and bigger within the intima. So the endothelial lining is still here, but what we see in the intima below the endothelial lining is these foam cells growing. Now, with the macrophages and the T lymphocytes, the white blood cells that are coming into the area, they're releasing lots of growth factors, which is changing the extracellular environment. So the other things we're going to start to see coming in here are collagen. So collagen will start to kind of intersperse in the foam cells. We also see smooth muscle cells moving in from the media, which also accumulates in with the foam cells. And the actual smooth muscle cells can also phagocytose and engulf these LDLs, which also make them foam-like in their appearance. So this fatty streak will just continue to grow and grow depending on the risk factors that are involved. Then we move to the last stage, the step 5, which is the advanced plaque.
If you're going back to school, before you submit your essays, run it through Grammarly to quickly check for spelling, punctuation, or
So it's really at this stage where probably the clinical manifestations will start to manifest, which I'll talk about in a second. But this advanced plaque is really where we start to see the problems occurring. So what we're starting to see is the size of the inclusion is getting pretty big. So it's starting to take up a lot of space within the blood vessel. Again, the endothelial cells are still lining the blood vessel, so they're still there. But we're just seeing a huge amount of foam cells. And what we're going to start to see is the middle part becoming this lipid core, which can actually start to see apoptosis. So the inner part becoming necrotic and dying off. Blood vessels will try to come in to feed this area, this growing area. There's a lot of connective tissue in here as well, and smooth muscle, particularly underneath this part. So it's becoming a quite established chronic plaque. Now, what's going to happen from here are the chronic manifestations. So this moves us into the third part of the lecture. What are the chronic clinical manifestations that you're likely to see with an advanced plaque? Well, most notably, what's going to happen is the blood vessel isn't carrying enough blood. So we're going to see ischemia in the area that it's supposed to carry blood to. So we're going to see ischemia to the brain, so early stages of reduction in blood flow to the brain. We're going to see a reduction in blood flow to the heart, so you might start to see ischemic heart disease. To the kidneys, so we're going to have problems with perfusion of kidneys, and then going down to the legs, so increasing the likelihood of peripheral vascular disease and gangrene in the lower extremities. So ischemia is going to be the first one. So chronic complications, number 1 is purely through stenosis. The example I'll give, stenosis will stay in the coronary vessel. Once the stenosis kind of gets to about 60 to 70% occluded, we're going to start seeing the symptoms associated with this stenosis. Before that, even though the atherosclerosis is becoming more and more present, we're probably going to be preclinical. So we're not going to see many symptoms. But once we get to this kind of stage where 60 to 70% of the blood vessel is now occluded, there's reduction in blood coming through to feed the heart. So if the person was at rest or doing very minimal physical exertion, maybe we wouldn't see any problems. But once the person starts to exert himself physically and we need more blood to the body, the heart itself is going to start to run out of blood itself. So that's from stenosis. So not enough blood is getting passed. And that's going to start to lead to ischemia. And this is what we call stable angina. It's a very predictable pattern of ischemia because it comes on with exertion, and that ischemia causes pain, and that's the angina that we see. So stenosis is kind of a critical stenosis, which is based on the advanced plaque, but just a reduction in blood flow. The number 2 is the unstable. The unstable plaque, which basically a number of things could happen. We could kind of take the top off it. So through ongoing hypertension, we take the top off that kind of endothelial cap and we expose this kind of collagen, which then causes a clot to start to form, which is a thrombus. So a thrombus will start to form, and that's going to cause a critical reduction in blood flow. So if that is in the coronaries, that's going to potentially lead to unstable angina or even into a myocardial infarction. If that completely occludes the blood vessel, we have an MI. If that's in the carotids, that could actually break off and travel up as a embolus and go up the brain and cause a TIA, transient, or a ischemic stroke. Other things that could happen is blood can accumulate in here. So instead of the clot forming there, we can actually have the blood vessels that are going there causes bleeding within that, and that's just going to also increase the size of that plaque, which again gets to a critical stenotic size. But in these cases, different to these are very unstable and can lead to very serious manifestations. Like I said, a heart attack or a stroke. And then number 3 would be more to do with the tunica media, which is the wall itself. And these would be aneurysms. And so with aneurysms, basically, such as the abdominal aorta, so the AAA, what happens is the wall starts to weaken and it will start to bulge out, or even increase the likelihood of rupturing itself. And so we have a rupture. An example would be a hemorrhagic stroke in the brain, and blood spills out and the whole blood vessel breaks. So these are the 3 main chronic complications that we see associated with atherosclerosis. We see just general stenosis associated with just the atherosclerotic plaque getting bigger and bigger. We see an unstable plaque where it's more associated with the thrombus, and then we have aneurysms or ruptures, which are associated with a breakage or a weakness in the wall. So there we have it. We've gone through atherosclerosis very briefly. We've looked at definite.
So it's kind of like, for me, that was a little easier to kind of understand than trying to read some of these slides. So basically what he was saying, you know, those lipids, the high density, the LDLs, low density lipoproteins, you know, they pass through that endothelial layers into the actual intimal layer of the cell, where those lipids start getting eaten or ingested by those macrophages, forming those foam cells, which start to grow and expand. So then some of the other cells, the smooth muscle cells from the muscular layer, enter into the subendothelial layer and become transformed. So you get start formation of those fibroblasts. So this is when we start developing that what is it? The fatty streak. When we start getting some introduction of that fibrous material from the fibroblasts. So those things, you know, it starts to grow and grow and grow, and then eventually you can wind up with basically degradation and breakdown of that fatty streak. And at this point, you know, the plaque starts to become unstable. So you get blood flow feeding into those areas where it starts to become necrotic. So here we have the normal cell. We got its response to endothelial injury. We got those white blood cells and platelets attaching to that endothelial layer. They enter into that through that endothelial layer into the intimal layer. Within that intimal layer, the monocytes start ingesting some of the lipids that are in there, turn into the macrophages. They turn into those foam cells. Eventually start growing and growing. You develop that fatty streak now. And then eventually smooth muscle cells start working their way into that intimal layer. The plaque becomes well developed. So this is basically, again, those 3 stages of formation. Starts, you know, with that abnormal infiltration of fat or lipid into that intimal lining. So this is that fatty streak that develops. That fatty streak eventually starts forming into the fibrous plaques, becoming more and more echogenic. The plaque is building up. Then it starts to become complicated plaque. So as it starts to break down and become necrotic, you can get bleeding into that plaque. The vessels, the actual vessel walls, provide some vascularity into that plaque. And this could lead to ulcer formation within that plaque. Also leads to calcifications developing. So it starts with that lipid core. That lipid core, that fatty streak turns more fibrous. Then the plaque becomes complicated, where we see areas of hemorrhage into the plaque, areas of necrosis, which can then eventually lead to ulcer formation and breaking down of that plaque. Plaque also becomes calcified, areas of the plaque can become calcified as well. So it's just a constant, repeating cycle of damage and repair that eventually leads to the narrowing of that vessel. Just kind of skipping over some of these. So I want you guys to be able to recognize plaques that have this intraplaque hemorrhage, these areas that appear anechoic, because these are the ones that are very critical for you to be able to detect on ultrasound, because these are the ones that have a very high risk for potential rupture and embolization. So these are very unstable. So I want you guys to be able to recognize these on ultrasound. So types
How,
of, yeah.
sorry. Sorry. How often do you see this type of thing in
In a patient?
no, like, yeah, like outpatient, are you gonna see this more like after they've already had an incident, or if they're really displaying
no, yeah,
symptoms in the ER or something?
No, you definitely would see it outpatient. I mean, if you're the first one finding them, usually like for a carotid scan, if it's not done, like kind of like as a pre-op thing for cardiac surgery, and they don't have, like, you would need an indication, so they might have some stroke symptoms. So they may have had like, a TIA or even a CVA, and they would want this to see, if that CVA or TIA was caused by some of these plaques. I mean,
So you might be visualizing something like that after an incident,
could,
and
yeah.
sometimes it'd be before, and they just happen to catch it.
Yeah, usually disease is bilateral too, so a lot of patients, it's very rare for them to have, one side completely normal and the other side is the one with all the disease. So yeah, so they may have had a stroke that came from one side and then the other side has, something that's pretty significant.
Okay, and then that could determine how much anticoagulation they're on, or how long they would stay on it, that type of thing.
Yeah,
Okay.
it also depends on the type of stroke too. So I mean, if it's an embolic stroke, yeah, they would need anticoagulation, but if it's some sort of hemorrhagic stroke, something that bled out in the brain, then they wouldn't necessarily be, that's kind of tougher.
That's like brain surgery, hopefully fix it type
Yeah,
of thing.
they would need yes, they would need a coil embolization to cut off stop that bleed.
We're talking Grey's Anatomy and
Yeah.
stuff at that point. Okay.
So uncomplicated plaques, these are stable, they're usually smaller, they're younger in age. So these are gonna be our homogeneous smooth plaques. The ones that, you know, start with that fibrous, the fatty streak and then develop a fibrous cap. The complicated plaques, they're larger, they're older. They're the ones that are gonna be heterogeneous. Those are the ones that are gonna have, you know, those areas that appear anechoic or hyperechoic within it, that show signs of intraplaque hemorrhage. Those plaques could potentially have that vascularity to it. So he said there could be feeding vessels into those plaques. Those are the ones that have a greater potential for embolization. So here's just that uncomplicated plaque showing a cross section of an actual vessel. That fibrous cap. It's largely homogeneous. And some examples of our complicated plaques. You see that intraplaque hemorrhage, that bleed, the ulcerations in that plaque. So this, you know, repeated process of breaking down and repair can eventually lead to some rupture of this. These are some, again, that complicated plaque. You see the area of hemorrhage within it. How it broke down. Even these areas look
Hey.
more heterogeneous. Yeah.
They did on the previous slide, complicated plaque. When it says C red clot, did the original image that have red on it? So say where the area is, what the clot was? The previous, yeah. Previous slide.
This one.
No, yeah. And C where it says red clot. That area. Okay. No, that's what I.
So remember you said that like sometimes you could develop blood clot on the top of areas that are ulcerated with some of these
Yeah.
hemorrhagic plaques. So this would be developing some clot on top of, you know, on top of that area. And then it gets sealed off with this, you know, fibrous layer. So, and you can wind up, if it doesn't seal off, that thrombus could potentially embolize as well. Here you're getting some of that thrombus formation on top of it. Getting some calcifications. So it's a good example here, a regular shaped heterogeneous plaque in that ICA. So it's heterogeneous, got areas calcified, you got that area that appears, you know, sonolucent or more anechoic. It's very irregular, the borders to it. So in terms of our common locations, when we're talking about our carotids, so think proximal. So proximal takeoff at the aortic arch, so right at the origin of our CCA on the left CCA. If it's the right, be like right at the takeoff from the innominate for the right CCA. The carotid bulbs. Again, that's the most common location for extracranial carotid artery disease. So our bulbs, and then our bifurcations right at that split as well. When we're talking about vertebrals, it's going to be the origins of our vertebrals. So where they come off the subclavian arteries. That's going to be our most likely location for plaque formation. This just kind of shows, you know, the areas. So in our aortic arch, for our three vessels, for our nominate, our left common carotid, our left subclavian. When we talk about vertebrals, the origins of our vertebrals, the origins of the right CCA, left CCA, our bulbs. Oh, our bulbs up here. Sorry. So E, F. So that's going to be our. Regardless, this is way more common than our origin of our vessels. So the most common location is going to be our carotid bulbs and bifurcations. I always say bulb and bifurcation. I could see also a common site in our carotid siphon. So where we get that little loop of our ICA and our circle of Willis. Right.
Is there another one?
Yes.
Okay.
That's why I'm gonna go kind of fast too, because there's some of these things that really don't. They don't.
Dan, you have my emergency contacts, right?
Do I need them?
I don't know. Nobody's home. So like if you see my head just hit the computer, you know.
Yeah, I do. I mean, I have your address now. I'd send 911 there.
Okay.
I'm not going down your contact list.
I'm just being dramatic. I just need to lay down. I'm gonna tough it out here.
You're out. I know. You're
It's
drained.
being recorded. Go sleep.
I might. I'm all right. I've been
All right.
sitting and relaxing all day.
So we're just gonna talk a little bit now about some exams that are potential options.
Yeah, no, I'm sorry. I'm gonna go to sleep. But thank you. Thanks,
All right.
Rochelle. I think you're right. All right. Okay.
Yeah, you look out.
Feel better, Brian.
Hopefully I'll see you all Monday. Thank you.
I feel better. You
Right.
sound terrible. Please. You sound like you're about to die.
Okay. All right.
Feel better.
Bye.
See ya.
Leave now. All right.
There you go. So you could potentially do a periorbital Doppler. So for this, we need to just be familiar with our basic anatomy and our ophthalmic artery. So ophthalmic artery supplies blood to the orbit, our eye, and the scalp and the surrounding surrounding the eye. So we have via the supraorbital artery, the frontal artery, and the nasal artery. So the supraorbital and the frontal arteries are communicate with that superficial temporal artery. So this is that communication we have between the ECA and the ICA is through these branch vessels. The nasal artery becomes
Are you trying to show us something by any chance?
Oh, I was. I'm not sure.
Okay.
Is that sharing now?
Yeah.
All right. ICA blood flows through that ophthalmic artery, through the superficial temporal and the facial arteries of the ECA. So we can get ICA blood flow through those vessels. So this is just a schematic showing our ophthalmic artery. So internal carotid artery going intracranial. Our first branch is that ophthalmic artery. We do have connections with the nasal artery as well as the frontal artery. can see our supraorbital artery. So with periorbital Doppler, so this can be used to detect hemodynamically significant lesions of the ICA by evaluating the flow direction in the supraorbital and frontal arteries. So with this, we're going to be looking for retrograde flow within those vessels. So with this, the patient is lying supine with the head slightly elevated. We're going to be using a non-imaging continuous wave Doppler. We position the patient supine with their eye closed. So don't try imaging with the patient's eye open. So here's a probe position for frontal artery. So I'm just going to kind of go fast with this because I don't ever anticipate you guys actually doing this. I mean, we have transcranial Doppler now if we really want to, you know, assess, you know, the circle of Willis and this flow. Chances are, you know, if we've done our carotid duplex and we see some sort of abnormality there, and, you know, that's the majority of where our lesions are going to be. If not, they've probably ordered some sort of CTE for the head, so we can evaluate the vessels that way. So this is not a very common exam. So we note the flow direction in the frontal artery. We do a series of compression maneuvers are performed to detect the presence of abnormal collateral channels. These compression maneuvers are performed on the same side and contralateral to the ECA branches and the CCA. So we do this temporal taps. We position, image the temporal artery. We're going to also image the facial artery. So basically, we're just looking for changes in flow direction to see if there's internalization of that ECA, if we're getting collateral flow through those ECA branches. We're looking for change of flow direction within that frontal artery, which would indicate change of flow direction within that ophthalmic. So abnormal peridoppler interpretation, we got retrograde flow in the frontal artery with when there's a lesion on the same side, or so ipsilateral ICA lesions are associated with retrograde flow. Reverse flow or decreased flow in the same side ECA branches indicates the same side stenosis. So limitations for this, we can only diagnostic for hemodynamically significant ICA stenosis. We can't tell the difference between a severe stenosis and an occlusion of the ICA. This technique requires experienced sonographer. So the posterior orbital Doppler. This is similar to that periorbital Doppler. This continuous wave is placed over the closed eyelid. We're looking for reverse flow to indicate ECA collateralization. So this procedure is another one that's also not very common. So this one applies a vacuum pressure to the eye to increase intraocular pressure above the point where the ophthalmic pulsations are obliterated. So this is basically doing plethysmography on a patient's eye, determining eye pressures. During the release of the vacuum, the point at which the pulsation returns allow for measurement of the ophthalmic artery pressure. So if we get a drop in ophthalmic artery pressure, this is consistent with an ICA obstruction. So we calculate a ratio that's an ophthalmic artery to systemic pressure ratio. The reason we don't do this is because we get really good direct imaging for a lot of our ICA lesions. So with ultrasound, we can get very good direct imaging. If we can't see it with ICA and it's intracranial, we can do CTAs, MRAs. So this was something that was more kind of old school, maybe before the advent of a lot of our MRA imaging and CTA imaging. This is just kind of a picture of the actual machine. Can you imagine actually having to do that to a patient? Like putting these little suction vacuums on a patient's eyeball? Like, I don't know, it looks kind of crazy to me. It's very like medieval torture.
I was imagining a shop vac, so I guess this is a little better.
So these are little suction cups that actually get attached to your eye, and then they vacuum suck to actually stop the pulse, increase the pressure to stop the pulsation of the pulse. And then they release it and see when that pulse comes back. That's crazy. So I'm kind of gonna skip that a little bit. All right, so this portion of the lecture is like kind of where I'm getting in for you guys that I want you guys to be familiar with and comfortable with. So waveform characteristics for our duplex. So we should be able to, kind of tell the difference between continuous wave versus pulse wave now. So you guys in echo now, when you image have you done continuous wave or played with continuous wave and pulse wave a little bit? Oh, hello, puppy.
Yeah,
A
we,
little, a little bit, or no? Did you try like LVOT? No. So when you guys are in echo, when you do continuous wave, your spectral tracing, it measures all the velocities along that scan line. So typically your waveform is going to fill in. You're not going to have a spectral window. Whereas with pulse wave, you get a much tighter envelope and you'll have a nice spectral window. So that's one way you could tell the difference, between pulse wave versus continuous wave is the presence or absence of that spectral window. So here's a good example. So continuous wave, completely filled in the spectral window. Pulse wave, you get a nice open spectral window. Again, continuous wave, pulse wave, ECA. So ECA waveforms, very sharp, deep dichrotic notch, much less diastolic flow compared to that peak systolic. ICA, when we compare that end diastolic to peak systolic, much lower resistance. So eyeballing Doppler angles, getting used to eyeballing Doppler angles, learning how to steer to optimize your vessel for color fill. What's a good Doppler angle? What's a bad Doppler angle? Being able to look at some of these pictures. So just recognize at least, that 2 and 4, these two, our angle of our ultrasound beam is almost perpendicular or 90 degrees to that vessel. So if we go down, this is our ultrasound beam coming in, our vessel's going this way. If we're at 90 degrees and we're trying to sample or Doppler, we're not going to get a waveform. We're not going to get a Doppler shift. So those are not good angles. So again, we want to try and be around 60 degrees, less than 60 is okay. So this is, closer to 70 degrees. So that's not a real great Doppler angle. We would have to steer a little bit more. Come at it at a different Doppler angle. So So I want you guys to recognize when we're perpendicular, our scan line is perpendicular to our vessel. That's not a good Doppler angle. So that was not going to give us any sort of Doppler shift. So if we had this question now, and we're trying to image this vessel, is this going to be a positive or a negative Doppler shift? So if this is the patient's carotid artery and blood flow is coming up the vessel this way towards that bulb, going up towards the head, ultrasound beam is coming in this direction. Is that going to be positive or negative? I can't hear you guys. I hear Rochelle saying positive. I think she said positive. Yeah, she did. You guys are all muted. Unmute yourselves. This is now the communal part of the lecture where we get to
Positive.
talk.
Positive.
Need to hear your pretty voices. So it's a positive shift. Good. So now just be careful because the boards will love to trip you guys up, and they'll give you something like this, and they'll ask you, if it's positive or negative, or they might ask you like which side of the baseline is going to be on. So if I had to draw my waveform, the way that's set up, my positive shift is below the baseline. So my waveform is going to be, look like something like that. It's going to be below the baseline.
Mm.
So just be careful, like, what your Doppler parameters are set up to. Draw a Doppler waveform on the spectral tracing to produce it. That would produce this Doppler shift. Produce the Doppler shift. So positive or negative?
It's at 90 degrees. That's no good, right?
Is it 90 degrees to the vessel? Like,
I guess not. Yeah, okay.
so just, you have to always look at it, the orientation of your vessel. So we're not 90 degrees to that vessel. So we're okay. It's going to be ICA. Looks like an ICA. So flow is towards the transducer. It's going to be above the baseline. Most likely the ICA. Oh. All I saw was a snout.
He would like to answer the questions.
Yeah. There you go. So looking at that one. So that one looks like you're kind of perpendicular now.
Yeah.
Yep, so 90 degrees. So in this case, we wouldn't have a Doppler shift. It would be very hard for us to be able to get a waveform. So in this case, we're going to practice when we get into lab doing some heel towing, angling back and forth to try and give yourself a little bit of an angle, or maybe come from a different approach. So we may have to steer a little bit more. Let this guy, we're gonna have a positive shift or a negative shift now.
Negative.
Negative, yes, negative. So this blood flow is going away from our transducer. So ultrasound beam's coming this way, blood flow is running away from that ultrasound beam. So it's gonna be below the baseline, good. Inverted. So if we're inverted, normally negative would be below the baseline. We're inverted, so it's above the baseline. So draw one of three possible Doppler beam angle cursor positions. Center, right, left, center, right to correspond with the spectral tracing. There we got an ICA vessel. That's kind of tortuous, goes up, comes down. So if we want our ultrasound beam angled to the right or to the left, to the center, or to the right, we can put it in three different locations to get, this spectral tracing. So you guys, as you start scanning carotids, you'll get more and more in the habit of understanding, where you can place your ultrasound beam, properly to get the best angles or Doppler shifts. So if I want to do a center position, I can Doppler that segment of the vessel. If I wanted to take a more angle to the left, I can have my ultrasound beam coming this way, Doppler that segment, or we could take a more right approach, an angle more that way. Trying to want to avoid those curves again. You can have a center position with 60 degree, or you could steer right with the 0 degree. Draw one of the three possible Doppler beam cursor, left, right, or center that corresponds to the spectral display. So this is now inverted. So it's going to be a negative shift. So that means we're going to be steered, in this direction. If blood flow is carotid going, from this side of the screen to that side of the screen. So we're going to want something steered in that direction. So this one again, looks like again, we're 90 degrees to that vessel. So no shift. Does this even work? Yeah, I guess it works. It flows away from the transducer. It's coming up around the churn. It's going away from the transducer. Not perpendicular to it. So this patient now would have a continuous subclavian steal. So here's our vertebral artery with our segments, intravertebral. So if we had to Doppler this now, and we wanted to draw something that had a subclavian steal. So if I was steering my ultrasound beam, in this direction, a negative shift would be antigrade. So if it's retrograde, then it's going to be a positive shift. So I would, if I'm steering this way and I wanted to show a subclavian steal syndrome, it would be above the baseline because it would be coming towards, it'd be a positive shift. That's a little tricky. So, you guys can see. Brian's gonna hate that he missed this. So if we had a vertebral artery and blood flow should be going antegrade this way. So if I had my spectral tracing, if I didn't invert anything, it would be a negative shift because it's going away from me, away from that transducer. So a normal vertebral, like normal would be, below the baseline. If I was angled in that direction. But since we're saying there's a subclavian steel complete and it's retrograde, so then blood flow now is coming towards my transducer, which would create a positive shift. So my Doppler waveform would be above the baseline in a patient who had a Steele syndrome. If I was angled in that direction. If I angled in the other direction, I did that way. Then blood flow normal would be antegrade, would be towards the transducer, which would be a positive shift. And then retrograde would be below the baseline. So it also depends on, the direction that you're steering in. So with the left steer, it could be, our steel would look like it was in that direction. A right steer would be the other way. So you just have to be aware when you're taking your boards and your tests, which direction are they steering? And is it a positive shift? Is it a negative shift? Is it antegrade or retrograde? So just kind of being able to look at your angle, know the normal flow direction, and then determine if it's positive or negative shift. So they'll have to tell you, if there's a Steele syndrome going on, if it's retrograde flow. So you'll get little clues in your questions. What would you need to do to obtain a Doppler signal from this transverse view? Nothing. You don't obtain Doppler signals from transverse views. Assessing flow transversely is not ideal and is not recommended to measure velocity this way. It can be useful sometimes to just determine, is this artery or vein? So you could potentially do that. But if you want to actually measure velocities, this isn't something that, isn't something that you would do. So this, we have to draw the appropriate waveforms for each of the basic beam steering positions. So this is now a horizontal aorta. So aortic blood flow goes from down the body, so it's going from A to C. So blood flow is going in that direction. So if we have a center beam position, we're going to be perpendicular to that vessel, so that's not going to give us any sort of Doppler shift. If we're angling to the left, I'm sorry, patient left. If we're angling to the right, C would give us a negative Doppler shift. And if we're angling to the right, that's going to give us a positive Doppler shift. So we'll have a waveform above the baseline for A, no shift for B, and then a negative shift for C. So what positions in this vessel can you take good Doppler samples? What do you guys think?
I mean, couldn't you take good samples from B?
Yeah, B is good.
I mean, wouldn't you technically be able to do any of them? If you have a position properly?
Let's see, B, yes. I think A, you can get a good angle at A, like coming from stern.
But
towards
not
the
C. Yeah,
C-
no, not
C
C.
might be a little more challenging. Yeah, C would be more, you're more perpendicular. So A and B have good angles relative to C. C was, you're more perpendicular when you kind of come from at that angle.
Mhm.
So this would be an instance where you can try and rock and tilt your probe. If you had to Doppler at C. Can you get a reasonable less than 60-degree angle and any position in this artery? That's a big no. So here we're basically perpendicular, no matter how we try and come at it. So we'd have to rock the probe, try and manipulate the lie of that vessel just by rocking the probe. So this is pretty similar to that previous question. You know, we get good angles at A and B. C, we're close to 90 degrees. On to an optical Doppler waveform from site C. What would be two ways to do it? You've seen A and B. If we want to get a good angle, if we want to Doppler at C in the middle there,
Rock the probe.
yeah, definitely rock the probe. Slide, just move your place in the vessel. So if you wanted to Doppler at that segment, just slide your probe up, move C to A or B. Thinking outside the box, right? So just move that spot of C to a different location or rock the probe, tilt. Good. Let me tell you, when they started imaging aorta, or they were doing aorta in here, and they were struggling because the aorta is kind of hard. It's just you're pretty much parallel to it. They were trying to Doppler at mid segment where the renal arteries are, and like they were just right over it. So they were where they wanted to Doppler. They were putting in the middle of the screen, and they're like, I just can't do it. I can't. I'm like, just slide down, like put it there. But I'm not at the middle anymore. Yeah, you're still Doppler in the middle. It's just over here now. It's okay. So will this color box angle produce good color? So assume this is a carotid artery now. So blood flow going up to the brain in this direction. Gonna be red or is it gonna be blue?
Wouldn't it be blue?
Blue, yep. It's gonna be a negative Doppler shift. Can you see that, Sydney? You can see negative Doppler shifts, positive.
Yeah, I do.
Yeah, I just wanna make sure you guys are okay with like being able to see it. If we want to increase those hues, we can try rocking the probe to make the vessel dive downhill, thus creating an angle closer to 0. We can also play with our scale or lower our PRF. So if we wanted to, again, make those hues brighter, we can lower our PRF or our scale to make it brighter in here, those shades brighter. or we can try and heel toe it, make it kind of run more. Dive more to give more of a Doppler shift on it, closer to 0 degrees. Will this produce good color?
Isn't it 90 degrees on there?
Yeah, so that's not gonna produce good color. We wanna steer the other way. Yep, looks like we're almost 90 degrees, so no, yeah. So we wanna steer, you can do straight box up and down, that'll work. Even better would be steering, to the right. So this picture may or may not show up on your final.
So like, are A and C, would they be blue and then B red when it goes over that little curve?
So we're assuming this is carotid artery, so blood flow's coming up this way. These are coming towards us, so this is a positive shift. So these would be red. And then it would, once it goes around that turn, this is gonna be blue now.
That's blue, okay.
Blood flow's coming up this way and going away. A would be red. B would be blue. C, probably black, no color, because we're kind of close to 90 degrees. Oh, God. Have any of you had carotids that are like this yet or seen any of this? No. So what color would be lettered at the site's imaged? Let's see, A.
A would be red, right?
It would be red, yeah.
And then B blue.
Yep.
And then C red again.
See,
Would D be black? Because of, I mean, it looks,
yeah, it looks like we're kind of perpendicular to that. Yeah, it's almost
Mangy.
90. I don't even know what mangy means. But yes, yeah, it would be not very good filling. Yeah, we're close to 90 degrees there. I mean, if it was gonna be color, it'd be some of these low hues of red. Cause it would still be kind of towards us, a positive shift coming towards that ultrasound beam. But not very good vessel filling. Yeah, but C is red, B blue, A red. Choose the color box angles that will give good flow, draw them in. If more than one angle will work, draw it and then, or them, draw it or them with dotted lines. What color will be produced? Let's see, I like Straight box would work. We can do a straight box. Here. So we're assuming again, this is a carotid artery, so blood flow is coming this way. So I would have red in that box.
Wait, you would want to do a straight, even though,
You could,
like,
it would work. Straight would work. This one would be better. I would.
Yeah.
Yeah,
it's not perpendicular, like when you look at it like that, the center? I guess not. No, okay.
yeah, so like if I draw my lines like coming down. Yeah. This one would make you more perpendicular or close to perpendicular steering the other way. You guys are gonna get good at steering, or you guys were good at steering already, but like, I'm trying to get the DMS girls to understand steering right now. We started in with arterial duplex. And I think they kind of get it, but. I mean, this is just gonna become instinctive now. When you start putting the probe down, you'll be like, all right, guys, steer this way. So straight box works, but steering to the left would be better. That's why I like the IU-22, the Phillips. So when you actually Doppler to get your cursor lined up parallel to that vessel wall, it steers the box with it. So sometimes it's almost easier to go right to your Doppler or do the color and Doppler like together. So you Doppler and you angle to line up your parallel to your vessel wall to get that angle correct. It's going to steer your color box and optimize your color box with that angle. So it's going to kind of steer everything with it, and it's going to optimize and make it nice, give you nice vessel filling. So you can Doppler and then, just take the Doppler function off and you should still have your color box in that same angle that you had to that positioned it when you were Dopplering. So again, straight and then steer towards the most dependent portion, of that vessel. And then just assuming this is a carotid artery again, so these are gonna be blues now. Color would be blue.
So that would still be straight, even though like it looks pretty. It looks like 90 degrees. Sorry, 90 degrees, like where it starts. Is that? Yeah. Well, maybe not. Maybe it's not.
Over here, yeah, definitely. Yeah,
Yeah.
it's not
Is
that great. Like, so this segment isn't gonna feel that great, but you get a fairly decent segment where you have a good enough angle here.
Okay.
It would work, like for the majority of that vessel. Like,
Okay.
yeah, if you want to move this over, over a little more towards this side and get away from where it's a little flatter, yeah.
Uh-huh. So you would still like accept answers, or the boards would accept an answer like that too, rather than like moving it over a little bit, or what if since
If you
like
had to do which is the best, steering is the best. Like doing your steer
Okay.
would be the better answer.
is that usually what they do? Like, what is the best answer?
Best, yeah, yeah.
Okay.
So here, if you wanted to assess this vessel, you have a couple options. So depending on which segment you wanted to look at, you could steer either way. So just realize your color box, keep things tight, keep things narrow, focus on specific segments of the vessel. So you don't have to try and fill up the entire thing with color, particularly when vessels become tortuous like this. So just pick a segment and go for it. So which site or sites are most important to classify the degree of stenosis created by this lesion? So the sites that are most important, we're gonna need D, we're gonna need C, absolutely, because that's gonna be our fastest velocities, and we're gonna need B after that stenosis. So our fastest velocities are gonna be within C, get post-stenotic turbulence. If you wanted to do a velocity ratio, D is very important as well. Does it say which vessel this is? Flow direction of this vessel. So this looks like CCA. So is this antigrade or retrograde? RL. I didn't say an RL. Oh, is it going to the right or to the left? I guess you were asking. She just wants to know if the blood flow is going towards L or going towards R.
Going towards L, right?
Yeah, it's going towards L. Yeah. So it's a negative shift. Blood flow is going in that direction, away from us. So it's headed towards L. I feel like I've done this other vascular test lecture in like every other class. Have I done it with you guys this year? Because I did it with the first years when we talked about other vascular procedures like last week. I just did it with like the second years. Angiography, MRA, CTA, nuclear medicine. I feel like we've discussed this already. So angiography, our gold standard. So this utilizes X-ray. We need contrast medium. So angiography is considered an invasive test because we're introducing contrast into the patient. So all those invasive, introducing contrast into the patient. And we need that contrast to be able to visualize the blood vessels. So this is a form of X-ray. They utilize a process called digital subtraction angiography, where the computer and the imaging machine, it gets a series of images and basically creates like a real-time cine loop by subtracting previous images from current images. So this is seen on our fluoroscopy monitor. So when you hear patients, they're going to fluoroscopy for an angiogram, this is all stuff that's done in the interventional radiology suites in hospitals. So we can use angiography to visualize any vessels. So this is kind of just the general term when we want to image the vessels. When we talk about specific arteries, that'd be in arteriography. When we want to look at veins, venography. So this is frequently used when we want to assess carotid stenosis, interventional procedures, when we want to do stents, angioplasty, endoarterectomy, well, not endoarterectomy, we use ultrasound for that. Stents, angioplasty, balloon angioplasty, potential bypass, looking at fistulas. If they want to do embolization of vessels, they want to stop bleeding the vessels, they would do this. What else? I'm trying to think. Atherectomy, potential thrombectomies. So the machine that they use for angiographies is it's a big C-arm ultrasound machine. So this was just showing again some guide wires. So guide wires allow for introduction of catheters into vessels. The catheter allows for us to be able to have access into the vessels once. So we access the vessels once. We leave those catheters in place that allow us to go in and out of the vessels to do whatever procedures that we need to do. So after the guide wire is placed, the catheter is threaded through. So catheters, they're described by their diameter or French size. So 3 Frenches equals 1 millimeter. I don't know what the plural of French is. Frenches. Francois. So these catheters, again, there are different types of catheters, depending on what the tip looks like. So these catheters, they can remain within the vessel. And prevent, us having to repuncture and allow procedures to be done. These catheters, we can, use them to introduce contrast medium, do our interventional interventional radiology procedures. So when we're removing these catheters, we also have to remember that we have to hold prolonged pressure over the puncture sites, hold manual compression in order to seal off those vessels, because then we worry about potentially causing a pseudoaneurysm. Before we do any of these procedures, patient's consent needs to be obtained.
Hey, Dan, I'm so sorry. I have to get going. I have to walk cricket before it is pitch black.
Go for it.
All right.
All right, I'll see you.
See you guys.
Just remember, angiography is the gold standard for evaluation for our vessels. It can be used before an endarterectomy or part of the procedure for carotid stent placement. This is just an example of our angio-interventional radiology suites. Images of our digital subtraction angiography when we want to image the patient's carotid vessels. So they'd be able to image this in real time, introduce the contrast, see the vessels filling with contrast, be able to visualize any stenotic areas that don't opacify or fill with color, presence of collateral vessels as well. So it's just a list of some different interventional procedures, interventional radiology procedures that can be done under the guidance of fluoroscopy or angiography. So we're talking about some of that percutaneous angioplasty, laser angioplasty, the atherectomy. So that's the actual mechanical removal of plaque. So that's different from, your endarterectomy, which is a surgical removal of plaque where they actually have to slice open the vessel and remove it. This atherectomy is that catheter that's got kind of like that grinder on the end of it that grinds up the plaque and sucks it up. We can use it for stent placement, thrombolysis, breaking up of thrombus within the vessels, the placement of filters, as well as doing it for embolization. So this is that coil embolization where the tip of the catheter either has a radio frequency on it or a heat source on it that actually heats up and cauterizes and closes off vessels. So we can use embolization to stop bleeds. And maybe it's a brain bleed, maybe it's a mesenteric bleed, abdominal bleed, GI bleed, something along those nature. So embolization is the process where we're stopping a bleed. This is just that balloon angioplasty now. So this is areas where we have focal narrowing or stenosis. Balloon angioplasty is a good choice. So with this, catheter is brought to the area where that stenotic lesion is. The balloon is inflated multiple times and smushes that plaque up against the vessel wall. the percutaneous angioplasty or balloon angioplasty. Seeks to improve blood flow supply by widening a vessel using a balloon catheter. So this is when we have discrete or focal stenoses that are easily treatable. And we're talking about stenoses that are due to these atherosclerotic deposits. We could potentially use laser to try and vaporize some of these plaques. This is laser angioplasty. Again, using that laser to break up the plaques and dissolve these blockages. The atherectomy. So this is that mechanical removal or shaving of plaque, these blockages. A couple different methods. This rotational atherectomy uses a high-speed diamond-tipped drill that's spun in the artery, resulting in very small particles being removed from the blockage. So there's also a suction on the tip of that catheter that sucks up those pieces so they don't embolize. There's also this transluminal extraction catheter that's specially designed that continuously cuts the blockage from the artery while removing the particles by vacuum. This kind of grinds and scrapes them up and then stores them here in this catheter tip. Gets sucked up. We can use our angiography to place vascular stents. So there are a couple of different stents. We have self-expanding stents and then stents that need a balloon to expand. So basically a stent is a metallic device that's placed within a newly opened vessel to keep it patent. So this might be an option, you know, after they've gone in, they've done the balloon angioplasty to smush that plaque up against the wall, reopen that vessel. They might decide, hey, we don't want to have to go in and do this angioplasty again. Let's put a stent in to try and keep that vessel open long term. You know, so maybe this is a patient whose renal artery they reopened. Maybe they're a little young, you know, they want to prevent this patient from having to come back to re-stent open their renal artery. They might decide, or re-angioplasty their renal artery. They might decide, hey, let's put a stent in, try and keep it open longer. So good thing about stents is they're easily, visualized on ultrasound, so we can pick up a stent by its echogenic walls. Embolectomy. So again, we mentioned before, emboli within those arterial vessels, there would be something that would be an acute process. So probably some sort of embolus coming from the heart getting lodged in one of our vessels. So these plaques or these emboli are typically very soft in nature because they're soft, fresh blood clots. You can easily puncture through it. So in this case, they advance the catheter past the actual blockage or embolus, inflate that catheter, and then withdraw the catheter and pull that embolus along with it. We can also do thrombolysis. So we can administer thrombolytic agents or medicines that can be designed to actually dissolve and break down these thrombuses in particular areas under the guidance of fluoroscopy. We also use it to place, our IVC filters or thrombus filters. Just remember these IVC filters, they're placed typically below the level of the renal veins in order to prevent thrombus from entering into those renal veins and creating nephrotic syndrome. And then we can use our fluoroscopy or angiography guidance to aid in embolization. So this is a procedure that introduces a substance, either a mechanical device or chemical material, to produce a temporary or permanent occlusion of a vessel. So again, this embolization procedure, we use it to control bleeding. So that's the main thing we do. Embolizations can also be used potentially in patients that have tumors. So we want to shrink a primary tumor, prior to a patient maybe doing radiation or chemotherapy. to starve that tumor of a blood supply in hopes to, to shrink the size of that tumor, maybe making it a little more operable a little more operable. So they'll go in, they'll embolize the feeding vessel to that tumor. They can use it for correcting arteriovenous malformations. So maybe a patient is born with an AVM. They want to fix that AVM. They can embolize those vessels that are involved. They can also use it preoperative to stem blood flow to a particular site or area that they want to operate on. Angioscopy. So this is actually direct visualization from inside the vessel. So now we have small cameras that we can attach to the end of our catheter and actually get images from inside of our vessels. In addition to the images, we can also get pressure measurements from inside the vessels as well. So here's an intravascular ultrasound image from actually inside the vessel. So this can help determine, the size of the stent that we potentially need, size of the balloon when we're doing balloon angioplasty. With MRA. So with this, we have, so MRA, out of the ones that we're going to discuss, is one that can be done either invasive or non-invasive. So remember, invasive, introducing contrast, or MRI could be done non-invasively. So this is one of the ones that, can be done without the administer of contrast. The images are better with contrast, not gonna lie. You typically get better images, particularly with vasculature when you have the contrast, but it can be done non-invasively. And with MRA, this one does not involve radiation as well, or X-ray, where CT and angio both involve X-ray. So this could be a potential option, particularly with patients that have poor renal function, because a lot of the contrast agents that we have to use for CTAs and angiograms are nephrotoxic, so they can affect the patient's kidneys if they have poor creatinine and BUN levels. If they have poor renal function, they may not be necessarily candidates for some of those procedures. So MRA might be a good option for them. Just remember with these MRAs, this is an MRI machine, so it's a large magnet. So patients, who have pacemakers, defibrillators, they may not be eligible. Any sort of implanted devices that are metallic, think hip replacements, maybe knee replacements. Even certain tattoos now have certain metal alloys in them. So, have to be careful with people with tattoos. I know my wife, she's got these eyelashes that stick to her eyelids using magnets. So she's got like this little metallic thing that she puts on. So even be cognizant. Yeah, exactly. Oh my God. Pulled by the eyes. Hold on 1 second. Hello? Hello? Hi, honey. I don't know. I haven't checked yet. I'm just in the middle of a lecture right now. I'm just like in the moment. No, I don't know. I haven't checked. No. Okay, that's good. With an address, yeah. I'm probably not gonna finish till like around 5. All right. All right. Okay. All right, bye. Sorry. So yeah, so just be cognizant. Thankfully, it's not up to you guys, to screen these patients. It's the MRI tech's responsibility, for ensuring, the safety of this exam, but just recognize, and be familiar with it. So MRs can be used for carotid arteries. You can get some very good images. Just the downfall of this is, these exams take a long time. The MRAs take a long time. They're very susceptible to motion. So if we need a stat emergent, result, we're worried about a patient who's had a stroke, or we're worried about some sort of brain bleed or something like that, MRA isn't the route that they're going to be going. They'll go right to a CTA or a CAT scan because that's much quicker. Utilize ultrasound. So this was showing just a narrowing on this time of flight. Intensity projection of the carotid bulge showed it showed luminal narrowing in the proximal ICA. And then with Doppler, we got a peak systolic velocity of 152. So that equals a 50 to 69% stenosis. So we confirmed what they saw in MRA. So CTA, this is our computed tomographic angiography. So this is similar to our traditional angiography or digital subtraction angiography. Just we're using now an X-ray tube that rotates around that patient. So it creates a cross-sectional image of the desired structures. So with this, we can see the vessels and we can see a lot of this. We can see the surrounding tissue and bone as well. So we see a lot of the surrounding structures. So this gives us a better, idea of what could potentially be going on in the patients. It's best seen again with contrast. Allows for relative accurate measurement of the residual lumen of these vessels. So traditional X-ray is just a single slice or a single view, whereas that CT, we get a cross-sectional slice showing more dimensions. Sample of our CT scanners now. So CT scanners now can actually reproduce and create 3D images, which are very nice. The CT scanners now use this spiral approach where the CT scanner is continuously running and the patient is just on a table that slowly moves into the scanner and then back out of the scanner to create a continuous loop of images with very thin slices. The CT scanners now are actually so smart that they've actually created them where they can detect the presence of contrast. So we've injected the contrast, hasn't gotten to the place where where we want to image yet. The CT scanner, once it actually detects that contrast, will start imaging. So rather than having this thing going and imaging and exposing that patient to radiation, the CT scanner can tell when the contrast is in the area where we want it to be, and then starts acquiring the images, and we push that patient through the scanner. So that, severely cuts down on the radiation exposure to on the patients. So here's just examples of our CTA images. Some of them showing. So this is digital subtraction angiography. This is our, enhanced MRA, and then this is our spiral CT. This is a volume rendering CTA. So we're able to get, 3-dimensional now volume rendering for our vessels. So this one showed a severe luminal narrowing. And then with ultrasound, we got 254, indicating a greater than 70% stenosis in that area. So we can also use nuclear medicine procedures. We can use a PET scan, a positron emission tomography, to provide some qualitative information for cerebral blood flow. With this, patients are scanned after a radioactive tracer has been administered into the patient. The radioactive tracer travels throughout the body and is collected by various organs, and it's collected by the various organs that are targeted for examination. So these images create functional images that show blood flow and metabolism. So here's just some of the patient preparations that are needed. So showing a PET scanner. So patients are injected with a trace amount of that radioactive isotope and placed on the flat table. So the table moves in increments through the scanner and contains a sensory array. As the isotope undergoes radioactive decay, it emits a high energy positron, which collides with electrons. The resulting signal are processed and form a thin slice image using color to indicate different levels of brain activity. So on the top is a normal patient. And the bottom was a patient that had recurrent TIA with a left ICA occlusion. So with nuclear medicine, I just kind of want to mention for you guys, since you guys are echo techs. I haven't spent too much time in Christiana Echo Lab. But I know back in New York, in my hospital at North Shore, in the Echo Lab, we knew when patients were coming from nuclear medicine. And if they had a previous nuclear medicine procedure, if they've been injected with these radioisotopes, we consider these patients hot patients. So the techs, the echo techs knew this, and they would actually wear lead when they were scanning the patients and doing their echoes, because they're in close proximity to this patient. They're maybe reaching over to the patient, and that patient is still giving off that radioisotope. So they're giving off that nuclear, radioisotope, and to protect themselves, they wore lead. So I don't know if that's something that Christiana does, or if it's common practice for them, or if they get the patients coming directly from nuclear medicine or not, but. So I'm not sure. I'm actually gonna ask one of the nuke med professors if that's something that the echo techs do, but that's something that they did in New York to protect themselves, like long term. So they knew that these patients were hot. They came from nuclear med, and they would wear lead when they were doing the echoes. So just something to keep in your mind. I don't know if they look at you like you're crazy, like you get your own lead to wear. I think she's here. Are you still here? Where you go? Orlando, Florida. No. Sorry about that. I was just talking with the nuclear med professor actually about that. And so she said that she did a study, like a whole research study on the amount of radiation that's released from these patients, and gave like people, monitor the dosimetry badges to measure the amount of exposure that they got. And they found out that the amount of exposure that comes off for the patients and that they are exposed to is very, 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 very minimal, if like nothing at all. And that actually the techs that wore lead, the levels weren't any different than people that didn't wear lead. So that's why they don't do it at Christiana. So I spoke to her. So yeah, she was actually involved in this whole like research study. That the scattering that actually comes at the radiation that's given off actually scatters, and that actually still gets like around the lead and through the into the text. And it's very, very small, minimal amounts that are really inconsequential.
You're not like everyday scanning patients that are hot either, are you?
Not usually. Well, no. Well, you might get one a day, maybe potentially.
Fair enough.
But yeah, she said the levels are like, it really did make a difference whether or not you had it or not. So. I don't know. Stop share. Where were we? So this is the last one. This one's quick. This is just some additional waveforms that we just need to become familiar with.
Dan, you're killing me here.
I
You're killing
am.
me here.
What happened when we missed a day? This was all going to be Tuesday. But no one decided to come in and play. This one's easy. This is just looking at waveform pictures. Is it an ECA? Is it an ICA? Share screen, this one. Right, you guys see that? No, this one.
Wait, which lecture is it?
This is 13, what, 13.4? It says, let's see. Yeah, 13-4, additional waveforms. There we go. Vascular 112, week 13-4. Additional carotid waveforms.
All right, I got it. I found it.
Normal carotid waveforms. Okay, so we got our CCA. So this is low resistance and our love child, our combination between our ICA and our ECA waveforms. Normal ICA waveforms should be nice low resistance. We have a nice fast upstroke and a nice gradual downstroke. High amount of diastolic flow. The further we get away from that bifurcation, we get more laminar, so we should get a nice spectral window. ECA waveforms, high resistance or higher resistance. Those, have a very fast upstroke, very fast downstroke, so it creates very sharp points. Those we have the deep dicrotic notch, much less diastolic flow. And then our vertebral arteries, these are considered low resistance. They should be similar in our appearance to our patient's ICA. Just lower velocities than the ICA. So these are our baby ICAs. There's our just our normal carotid waveforms. So CCA, fast upstroke, fairly fast downstroke, but we still have a good amount of diastolic flow. Whereas compared to our ICA, we got a lot of diastolic flow, so this is much lower resistance than our CCA. ECA, very sharp peaks, deep dicrotic notch, much less diastolic flow compared to that peak systolic. So this is going to have a much higher resistive indice. I'm sorry. Oh, that's ECA. Oh, that was a CCA. That almost looks like ECA. There's ECA. Sorry. Sorry, those are both CCA. So ECA, again, very deep dicrotic notch, sharp peak. Vertebral arteries look very similar to your ICAs. There's ICA, a lot of diastolic flow, vertebral, low resistant, a lot of diastolic flow. I'm just going to kind of go through these fast to the ones that we haven't seen. So aorta, CCA, bulb, we get kind of this disturbed flow pattern. That's why we usually don't Doppler in the bulb. ICA, and then we got middle cerebral artery up there. I want to get rid of that because there we go. Then our ECA waveform, then our sharp peaks, deep dicrotic notch. This is a normal posterior circulation for our vertebral artery. So there's our subclavian artery, right at that origin. The V1 segment, vertebral artery, V2, V3, working our way up. All right, so patients who have high cardiac output. So this is both of you, young patients, active patients, healthy patients. We might have elevated velocities just because the patient has a high cardiac output. So these peak systolic velocity measurements may be overestimated when we're talking about the ICA because that patient has a high cardiac output. So they may not have any stenosis, but the velocities are just elevated due to high cardiac output. So we see increased peak systolic velocities without any evidence of stenosis or wall irregularities. With patients with high cardiac output, this is going to be seen bilaterally. So both sides should both be elevated. So if one side is low and one side's high, that's doesn't jive. That doesn't make any sense. So this is something, if we want to just say it's due to high cardiac output, it has to be seen bilaterally. On the flip side of that, we can have patients that have low cardiac output. So this is your little old 90-year-old lady, EF of like, 10, 15, well, I don't want to say 10, but like 20, 30%. We're going to see very low velocities throughout the carotid artery system because that heart is just very weak. It's not injecting the blood very forcefully. So here we see velocities, in the CCA 40s, 50s. This is even lower, this would be maybe someone with a very poor ejection fraction. Maybe they also have some aortic stenosis on top of that as well. So if we see it bilaterally, again, this has to be something that we see equally on both sides in order to say it's low cardiac output. If you see something like this, Tartarus parvus waveform, very low velocities on one side, then you have to all think, all right, this is due to some sort of proximal obstruction or proximal blockage. So maybe something at the origin of the CCAs that would be causing this potential waveform. So when we're Doppling, we could tell if a patient has elevated heart rate. So we know who's had their coffee in the morning. Versus someone who's nice and calm and relaxed. And we can also tell patients who are very bradycardic. So we know again, patients that have poor ejection fractions. We're gonna see diminished velocities. And those diminished velocities should be seen bilaterally again. So poor EF, low output. We should see low velocities seen bilaterally. So our tardus parvus waveforms are post-stenotic tardus parvus waveforms. So these are seen distal to a high-grade stenosis. So don't get confused with your terms. I can see Brian already going, oh, distal, proximal, like trying to wrap his head around it. So tardus parvus waveforms are seen distal to a high-grade stenosis. So where's that lesion? The lesion is proximal. So now your brain is going, all right, proximal, distal. So just remember that a tardus parvus waveform is seen more distal, so that lesion's got to be more proximal. So when we're talking carotid arteries, tardus parvus waveform, the disease is proximal, so maybe at the origins. If we're in the ICA, say we're mid or distal ICA, and we see tardus parvus waveforms, the disease would be proximal ICA or in that bulb, or maybe in the CCA. So that's how these boards questions are going to word these things. They're going to be like, all right, tardus parvus waveform seen, just talking vascular in general, seen in the distal subclavian artery. The lesion would then have to be somewhere proximal. So if we're talking, on the patient's right side, innominate, proximal subclavian. So that tardus parvus waveforms, these have prolonged systolic acceleration. So we have a long acceleration time. They're low velocity. They're low resistance. So those are all the characteristics of tardus parvus waveform. So here we give some nice examples of tardus parvus waveforms. So delayed upstroke, that's that tardus parvus or tardus part of it. The parvus is the slow velocities. So again, you have that slow upstroke, low velocity. So if we ever wanted to measure acceleration time, this is our AT or acceleration time. The time it took to get to that peak systolic velocity. These have prolonged acceleration times or long acceleration times. So you might not even get a waveform. So sometimes the vascular boards will throw you questions just giving you acceleration times for two vessels. So the one that has the longer acceleration time, this longer AT is the side that has the disease. So disease causes tardus parvus waveforms, which are seen with these prolonged acceleration times. So this is CCA with a patient that has a carotid valve, aortic valve stenosis. So here we see some tardus parvus waveforms. Decreased peak systolic velocity, so we've got very low velocities, but we don't see any sort of plaque. With a delayed upstroke, and this is due to a patient with an aortic valve stenosis. So with this, we would see it bilaterally. Again, the aortic valve stenosis caused tardus parvus waveforms throughout the carotid arteries. So we see it on both sides. So arrhythmias or AFib, a common arrhythmia. So this is why I'm a big proponent of letting your waveform run. So I see a lot of times, a lot of techs get in the bad habit of only capturing one or two waveforms, measure and move on, rather than getting entire tracing. So if I did that, say for this beginning segment, I just got these two waveforms and then stop measuring or stop recording my tracing, my waveforms, I would miss this potential arrhythmia. So atrial fibrillation is our most common arrhythmia. So we can pick these up very nicely when we're doing our common carotid waveforms. So when we want to measure these two, typically after that arrhythmia or that irregular one with the irregular heartbeat, we get a higher velocity. So you tend to want to measure one that's kind of average. So we can see the heartbeat, and then we get our arrhythmia. And then the one immediately after that arrhythmia is typically a little bit higher than, say, the one in the arrhythmia. There's another arrhythmia one. We get some more carotid arrhythmias. So we see differences in this diastolic period. So a very short diastolic period here, and these longer diastolic period. So patients that have severe arrhythmia or severely irregular heart rhythm, it can be very challenging to try and measure, what the peak systolic velocity is in some of these. So it's hard to determine what a reliable peak systolic velocity. So in this bottom one, you maybe take the average one, between some of the high ones and some of the low ones, try and measure maybe like one that's something in between. So some of the things that we can pick up with our carotid Dopplers would be a condition called pulsus arteriens. So this is a situation where the amplitude of the regular pulse is large and we get a small alternate pulse. So we got alternating between large and small, large and small. So the second beat is usually smaller than the first beat. First beat is typically larger. So this condition can be caused by idiopathic dilated cardiomyopathy or potential left ventricular dysfunction. There we go, pulsus arteriens. So we got alternating pulses, alternating high, high and low, high, low, high, low. So this is pulsus bispherians. So this is referred to as a double peak now. So with you and Andrew, you guys probably have a double peak when you're imaging your carotid arteries, particularly in your CCA. So this is actually normal because you guys are young, you have very elastic vessels. So this double peak is actually a normal finding, but you just have to be aware of which one peaks higher. So normally in a patient that does not have this condition, the first peak is higher than the second one. But if you see that second peak higher, then this is that condition, this pulsus bispherians. So here in this case, the first peak is lower and the second peak is higher. So this is abnormal. So here we see a higher second peak as well. Lower first peak, higher second peak. Lower first peak, higher second peak. So for you guys, this first peak is going to be higher and the second one is going to be lower. So that's considered normal in a lot of patients. So this is okay. This is a double peak normal because that first peak is higher than that second peak, first peak higher. So this is okay. This is normal for a patient CCA and could be seen in a lot of patients. This is abnormal. This is that, so this can be seen with aortic valvular disease, aortic stenosis, aortic insufficiency, as well as hypertrophic obstructive cardiomyopathy. So HOCM. So you guys get into your cardiomyopathies. So this patients that maybe have an LVOT obstruction, aortic valvular disease like aortic stenosis. So it's a late peaking aortic velocity. Pulsus paradoxus. So you guys are going to learn about this too in echo, go into this a little further. So this is when we get alternations in our velocities with inspiration and expiration. So with patient breathing in and breathing out, we have changes in the velocities. So with inspiration, those velocities go down. When the patient breathes out, we get an increase in velocity. So the reason this is important is you could be doing a carotid Doppler and maybe no one has picked up on this. Hopefully they did when they did an EKG. But this could potentially indicate something called cardiac tamponade, which is a very serious condition. So with cardiac tamponade, the patient is developing fluid around their heart, a pericardial effusion that's creating compromise to the pressure within the heart. And basically things are slowing down within that heart. So pressures are starting to equalize now due to this fluid building up. And the heart is essentially coming to a stop. It can lead to sudden cardiac death. So that's a serious condition if you see this pulsus paradoxus. So something that you guys might encounter would be a patient who's got an intra-aortic balloon pump. So again, a lot of times we're doing these carotid Dopplers for patients that are pre-surgical heart patients. So these patients that are, you know, pending coronary artery bypass surgery, they might be on a balloon pump. So this balloon pump actually helps to take some of the stress off of the heart and help promote and increase cardiac coronary artery perfusion by changing some of the pressures within the aorta and allowing for more flow to enter into the coronary arteries. So this is actually a balloon that's placed in the actual aorta that inflates and deflates and creates this, and will create a very particular waveform in your carotid arteries. So this is oscillating waveform. So one is due to the natural contraction of the heart and the other is due to the actual balloon inflating and deflating. So it almost looks like two pulses. So this one is the one that's due to, so this is the patient's natural carotid artery or carotid natural heart creating the pulse. And this is due to the inflating and deflating of the balloon. So when you're doing your carotid Dopplers, sometimes it'll be okay to actually ask the nurse or the doctor to turn off that balloon pump for you to do your carotid duplex study. So I've asked the doctors to do that. Now, some nurses will look at you like you got three heads, but like, what? I can't turn this off. Like, no, you probably can for a little while I do my study. Because it'll help you to be able to correctly get correct velocities. Because this balloon pump, you know, will actually sometimes skew some of your velocities and make it hard for you to figure out, like, you know, what peak systolic and diastolic velocities are. So this is a good example of, you know, a patient with an intra-aortic balloon pump. Looks like, you know, they got two heartbeats going on. So you'll know right away when you put your probe down. Oh, you'll know the machine. You'll hear it. It's actually quite loud. And it'll be sitting at the foot of the bed, and it looks like I'll have like a canister of gas in it. The balloon pumps. These are intra-aortic balloon pump waveforms. So again, temporary deactivation of these balloon pumps may be necessary to measure flow velocities. So the balloon pump may complicate analysis of underlying carotid disease. So you can see this is a good example, patient with the intra-aortic balloon pump. Can be kind of hard to figure out, all right, what's the regular waveform versus the balloon pump, and measuring, peak systolic and diastolic velocities. Because like really, what's your end diastolic velocity here? Because the balloon pump fired, you're not really getting a true end diastolic velocity. Particularly if you have machines that will automatically measure for you. There's some ultrasound machines that will do auto calculation, and that it'll drive that auto calculation completely bonkers. And then you have to go back and try and remeasure yourself. So oftentimes it's a lot easier to have them just temporarily turn it off if you can. So this is something that we're encountering more and more, patients with ventricular assist devices, particularly LVADs. So LVADs are most commonly, they could have potential for a biventricular assist device that goes to both right and left ventricles. So these are surgically implanted with one end connected to the left ventricle, the other end is attached to the aorta. So these are mechanical hearts. Mechanically pumping blood flow out of the heart to provide mechanically pumps blood flow to the heart to provide and aid in ventricular function. So when we try and image the carotid arteries, you're not going to have a normal waveform in a patient that has an LVAD. So if you know the patient has an LVAD, you have the right to kind of question, why are we doing this exam? What's the purpose of the exam? Because you're not going to get, accurate velocity measurements. You're not going to get anything that resembles a normal, cardiac cycle or normal velocities. So, your velocity measurements really go out the window with these. And just be very careful because it's not going to look normal at all. Again, our velocity measurements are unreliable with patients with LVAD because really, it's not the heart that's pumping, it's this machine. So you really have to go more based on your 2D assessment, your color assessment. Someone with a biventricular assist device. All right, so those are LVADs. Subclavian steal, almost done. So just remember with subclavian steal syndrome, we can have complete steal versus an incomplete or partial steal. So when we're imaging our vertebral arteries, any deviation from what looks like a normal arterial signal, or what we should expect, even though it's not below the baseline, this does not look like a normal looking vertebral artery signal. So this would be indicative of a mild or a partial subclavian steal. So incomplete or partial steal. So here we still have that crouching bunny, but we get now some flow reversal component to it. And then this would be complete flow reversal or complete retrograde flow. This would be indicate a complete steal syndrome. Hey, why are you doing that? Acting all weird. Just recognizing when we're imaging our vertebral, this indicates a partial steal. So you always want to just, compare this to your common carotid vessel. Particularly in cases of complete steal, you just want to make sure your transducer isn't flipped the wrong way, that your notch is in the correct position. So just always double check yourself. you know, particularly if you're on the left side, you know, I like to, you know, fan back and forth between, maybe I'll even show them a clip going from CCA with anti-grade flow, keeping your same angle and orientation of the vessel, fan out then to the vertebral and show that it's truly retrograde. And then if you do indicate, you know, have any evidence of subclavian steel, whether it's complete or partial, go look at those subclavian arteries. So try and get a proximal subclavian artery velocity, look for any stenotic lesion in the subclavian artery. If it's the right side, you know, try and image potentially a nominate artery. And then also, you know, be cognizant of what your waveforms look like in your CCA. So if it's a nominate artery, you should have some sort of flow disruption in your CCA, maybe a tartus parvis waveform. You might even have a steal in your CCA, depending on the severity of that occlusion as well. On the right side. So the boards will want you to recognize, you know, is that subclavian steel, or is that stenotic lesion in the subclavian, or is it in the innominate? So retrograde flow or partial steel in that left vertebral will indicate a left subclavian steel. So the stenotic lesion has to be in that proximal subclavian. On the right side, if we see right vertebral steel only, then that would be right vertebral that's affected. If we see any sort of flow disruption in our right CCA, then it's a nominate steel or a nominate artery occlusion. So internalization of the ECA. So this is when our ECA exhibits ICA waveform characteristics, or it looks like an ICA. So when would we see this? When would we see the ECA looking like the ICA? That's when we have occlusion of our ICA on that same side. So now our ICA is occluded, it's blocked, we're getting no flow in that ICA. That ECA now is taken over due to our collateral channels opening up. So we have that, again, collateral pathways between the ophthalmic artery and branches of the ECA. Those connections have opened up and been made. We now have retrograde flow going on in those vessels. That ECA now has blood flow going to the brain due to those collateral channels. And we're going to wind up with internalization of that external carotid artery. So we get that ECA becoming the internal carotid artery. So we call it internalization of the ECA. And that is due to ICA occlusion on the same side. We could potentially have retrograde flow in the ECA. So if we see retrograde flow in that ECA, there's only one condition that's going to cause that, and that's an occlusion of our CCA. So our CCA is occluded. There's no flow getting in there, but our bifurcation is still okay, still patent. In order to get blood flow into that ICA, we're going to steal it from that ECA. We've got retrograde flow in that ECA, come down the ECA and then into our bulb and then up the ICA. And that would only happen in cases where we have an ICA occlusion. So we can have externalization of this CCA now. So our CCA becomes very high resistance. So we have a high resistant dampened waveform. So we would see this in patients that have their ICA occluded on the same side. So if a patient has good development of ECA to ICA collaterals intracranial, that CCA may not be externalized, so it may not be high resistance. So just keep that in mind. So when we Doppler that ECA, we might see very high velocity, low resistant flow because we've developed some nice collaterals between the ECA and ICA intracranially. Carotid dissections. So here we can see again our nice telltale intimal flap across that carotid artery, separating a true lumen and a false lumen. So really the best way to tell the difference is by Dopplering. So when you Doppler, the true lumen will have a relatively normal spectral tracing, whereas that false lumen here, they actually open this sample gate across the entire thing now. The false lumen showed some retrograde flow. Here they were actually Dopplering just in that false lumen, showing a pre-occlusive Doppler waveform. Pseudoaneurysm. So I don't like this pseudoaneurysm picture personally, because you don't really see that bidirectional flow very well. I would have moved this baseline up so you could see more of that bidirectional flow. But this is the example that they gave for bidirectional flow in the neck of a pseudoaneurysm. Just remember, usually this is due to some sort of trauma or surgical or interventional procedure where they went in to try and access maybe a line, central venous line. They messed it up, poked the artery. So this is something called a water hammer waveform. So for you guys, this would be something in patients where they have severe aortic regurgitation or insufficiency. So severe AI would cause this holodiastolic flow reversal. So this is something that you probably see in the proximal segments of your common carotid arteries. For you guys, when you start imaging an echo, your guys are going to be imaging your descending thoracic aorta. So you have your aortic arch and then the descending thoracic aorta after that aortic arch. You're going to Doppler in there when you do your suprasternal notch view. Patients who have severe AI or severe aortic regurgitation, one way that we can call it severe is if we have holodiastolic flow reversal. So systole, we get forward flow, and then diastole, we get a complete flow reversal. We can also pick that up in this proximal carotid arteries, particularly on the left side. We should absolutely pick it up on the left side because it's coming right off that aortic arch. We can also pick it up in the proximal on the right side as well. And this would indicate aortic regurgitation. So this is a water hammer waveform for our carotid Doppler when we get this holodiastolic flow reversal in our carotid arteries, in our proximal CCAs. We got normal, velocities during systole. Just during diastole, we get this flow reversal due to blood flow just coming retrograde due to that leaky aortic valve. Yep, so patients who have severe AI, when that valve should be closed, if that AI is, considered severe, you'll actually wind up during diastole when that valve is closed, getting blood flow retrograde, going back up the aorta around that arch through that valve. So it's enough to pick up holodiastolic flow reversal in that descending thoracic aorta when you guys are doing echo. And then it's enough to pick it up in our CCAs as well. So during that diastole period, we're getting retrograde flow during diastole coming back down our CCAs on both sides into that aorta and through that aortic valve. So here we even see it in the patient's subclavian artery. So they say pan-diastolic. So that can also be used interchangeably with holodiastolic. I like holodiastolic because it's throughout all of diastole. So that's the words that we use in echo is holodiastolic. So systolic thumping. So this is something that we see immediately proximal to high-grade stenosis or occlusion. So a vessel that's completely occluded or has a very, very high-grade stenosis. If we Doppler just before that, we're going to get this systolic thumping or thud. So all we get are little blips of systolic waveforms. You might even get a little bit of reversal where it's hitting that thump and coming back, or hitting that blockage and coming backwards. So these are all going to be very low velocity, very high resistance because there's no blood flow getting through. You got a big blockage in front of you. So there's major resistance to that blood flow. So we can have little reversed or no diastolic flow seen. All right, quiz time.
Artist Parvis for number 1, right?
Good, yes, starters parvers. Thank God you recognize that. What about number 2, Sydney?
Okay. See, I don't like how you just put me on the spot like that. I was just literally cussing to myself about how I needed this to be over.
You got this. Got 2 more slides. We're right there.
Is it the arrhythmia?
Yeah. So
Is it
what is the-
or no?
yeah,
or is it the-
it's more specific. So we're alternating high low. So
Is
I
it
see
the paradoxus one?
nope. It's pulsus arteriens. So
Oh,
pulsus
because it's alternating. Gotcha.
alternating, alternating high low pulsus arteriens. Yep. Pulsus paradoxus, you get more like it would follow their breathing. So with inspiration, you get a series of larger ones. With expiration, no, sorry, I did the other way around. Inspiration, you get a series of smaller ones. Expiration, a series of larger ones. But like with pulsus paradoxus, you'd see a bunch of small and then a bunch of larger ones following their breathing. Anyone want to try number 3?
I have no idea what that one is.
So there's a couple things going on here actually. So I kind of know what it is. Like, so what do you think they're doing over here? What does this look like potentially?
I want to say retrograde, but I'm not sure.
Say it louder. What?
Retrograde.
Retrograde?
I'm not sure though. Unless
So right
wait,
here,
is it? Wait, is it a trigemity?
Oh, it's the tapping on the
Oh.
so they're actually doing a temporal tap.
Okay. So it's an ECA.
So they Doppler, they put the program, they're like, I'm 90% sure this is the patient's ECA. Like, what's going on here? It looks like ICA. They temporal tapped. All right, I got a temporal tap going on, so that is ECA. I proved it with my temporal tap, but it's very low resistance. So this is internalization of the ECA. So this ECA has become internalized. It's very low resistance. So they proved, this is internalization of the ECA by doing that temporal tap. Sydney's like, I'm gonna kill you. Andrew got it. All right, Andrew's on my boat.
I got it. Makes sense
You
though.
got it. Makes sense. So this ECA has been internalized. It's now it's acting like the internal carotid artery because on that side, the patient's internal carotid artery is probably occluded somewhere. So ICA is occluded. There's no blood flow getting up there. The body's going like, oh crap, I need blood. What can I do? It's calling out for help. Hey, ECA, can you help me out? Those collateral channels opened up between the ophthalmic and the ECA branches. So now the ECA can bring blood flow to the brain because of those connections that are up here. So now that ECA is acting like the ICA because the ICA is occluded on that side. So maybe they didn't see the ICA. They couldn't find it because it's occluded. They couldn't see it. They just see this one vessel. They're pretty sure it's the ECA, but they Doppler it. It looks like an ICA. Like, oh God, it looks like an ICA, but I'm pretty sure it's ECA. They temporal tapped just to prove that it was the ECA. In this case, this was internalization of that ECA.
That's the bad version of what you said City 9 might naturally have, or like the
Yeah.
second little hump.
Yeah, so
is
when
bigger.
that second peak is higher, this is pulsus biciferans. So this is a vertebral artery now. This is like this looks
Crouching
like
bunny.
Crouching bunny, yeah. So this is subclavian steel.
And then that last one's the proximal thumping, right?
The thumping, yep.
I'm still drawing my crouching bunny for the
Crouching bunny.
subclavian steel. Yes, I'm drawing them, so it's easy to remember.
Crouching bunny, hidden dragon, or was it Crouching tiger? I think that was a movie that came out, right? A kung fu movie, right? Crouching tiger, hidden dragon.
Oh yeah.
I thought
Like
it
back
was
in the
striped
day.
tiger. But okay.
All right, we're almost there. What's this one?
That's the balloon pump, right?
Aortic,
That's the
yep,
second heartbeat.
aortic balloon pump, good.
And then water.
Water hammer,
Yeah.
yeah. So this is with aortic insufficiency, severe AI. And this is crappy, but it's supposed to be your bidirectional pseudoaneurysm. Wow. I know, it's really bad in this one, but this is supposed to be bidirectional, like forward and then backwards, so neck of a pseudoaneurysm. But when we're talking carotids, again, that's gonna be very rare. If a patient's got a carotid pseudoaneurysm, that's like a huge medical emergency. They're taking that patient to the OR. And they would know, they would have a big bulging like thing on their neck, like. Cause you imagine, like, if the carotid artery has a pseudoaneurysm bleeding out, where's that blood gonna go? It's gonna, like, it's obvious. That's it, the end. So you guys are now carotid masters. Now we just gotta practice scanning them. Get you good. Sure. Gordon.